Flags.
The Ways and Means Committee will now come to order. The chair has determined that a quorum is present. We are holding today's meeting in a hybrid format in compliance with the rules and regulations for remote committee proceedings pursuant to House Resolution 8. I want to remind you of a few procedures to hopefully keep these proceedings running smoothly. First, consistent with regulations, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting themselves when they seek recognition or when recognized for their 5 minutes. Committee staff will mute members only in the event of inadvertent background noise. Second, when members are present remotely in the proceeding, they must have their cameras on. If you need to step away to attend another proceeding, please turn your camera and audio off rather than logging out of the platform. Finally, when a question is put before the committee, members who are present on the WebEx platform are reminded to unmute themselves for a voice vote. Before we get to the committee business of the day, I want to recognize and bid a fond farewell to the committee's general counsel and parliamentarian, Danielle Brown. She has been a force in this institution for more than 2 decades. Coming to the Ways and Means Committee nearly 4 years ago after dutifully serving the Judiciary Committee, Danielle knows the rules of the House inside and out. Her insight and intellect guided this committee through the unprecedented challenges of the pandemic as she put in countless hours both behind the scenes and up here on the dais. We can always count on her to keep us on task, and non-germane amendments never, with Danielle, stand a chance. I must also thank Danielle's husband, Mitchell, and daughter Harper, who have supported her through the demands of a job like this. Danielle, you've done a great service to this committee, to the Congress, and to America. You will be missed. We all wish you the very best in the next chapter. With that, let me turn to today's business. First up, we will mark up legislation in honor of our late colleague, the ranking member of our committee's Worker and Family Support Subcommittee, Jackie Wolorski. We've had the privilege of being joined by the late Congresswoman's husband, Dean, her mother, Mert, as well as our own former Congresswoman Susan Brooks, an alum of this institution, and one of Jackie's district staffers, Sharon. Thank you all so much for joining us in the room this morning. We know how much Jackie loved you, but you should all know how much we all loved her. You have been in our thoughts, and you have our deepest condolences. Congresswoman Wolorski was a champion for women and children in her district and around the world. She was a leading part of the negotiations for the bill that we will take up this morning, and she was taken from us too early. The negotiations have continued after her passing, and we have reached an agreement, putting to bed the argument that we only do red state issues or blue state issues in this room. In fact, there were hearings on virtually every one of these issues, either at the full committee level or the subcommittee level during the course of the last 2 years. I am very proud of the wide bipartisan support this legislation has received. Thank you, Dean, Mert, Sharon, and former Congresswoman Susan Brooks, who we want to acknowledge, who is here with us today, Congresswoman Brooks. Home visiting is a powerful program that helps young children and new parents thrive by meeting them where they are. Positive outcomes are well documented, from decreasing maternal mortality and morbidity to improving school readiness and promoting family well-being. It's clear that Mcv works, and I've seen that personally in my hometown of Springfield, Massachusetts. The Jackie Wolorski Maternal Child Home Visiting Reauthorization Act doubles the federal funding for home visiting over the next 5 years. This is the largest funding increase in its history. It also means predictability for states and territories to strengthen the program's most important resource, its staff. The bond that home visitors form with parents and children is what sets this initiative apart. With this reauthorized bill, we will be able to serve even more eligible families, retain talented workforce, and maintain the high standards of effectiveness. Back in February, this committee held its first hearing on mental health in more than a decade. We had an outpouring of interest demonstrating just how urgent the need for action is, and that's why today we are considering a series of bipartisan bills that our members have worked on together on, again, a bipartisan basis. What we are considering this morning is the product of a lot of hard work from both sides of the aisle. I want to applaud all the members that were involved, because frequently it's hard today in this full chamber to see that type of bipartisanship. The American people are better off for our efforts here today. Over the last several years, we've made great strides and recognized the importance of caring for our mental health as a society. But even as the conversation has progressed, far too many face difficulties in accessing the services that they need. The care workforce hasn't been able to keep up with demand, and insurance plans don't often cover expanded care. But with today's markup, we are strengthening mental health across the continuum. We will consider bills that range from expanding access to a variety of mental health counselors to improving transparency for patients searching for new providers or the health coverage that's best for them. We will also address important changes to the Medicare program, widening access to mental health care for this critical population. We take important steps to better protect victims of sexual assault from surprise medical bills and out-of-pocket expenses. Many of these bills built on past bipartisan committee work and ultimately have led to a system that is easier for consumers. This is extremely important work, and I can't thank all of the members enough for staying the course and working for a deal. Your contributions will deliver a more accessible, transparent health care system for the American people. Now, let me turn to the ranking member, Mr. Brady, for the purposes of an opening statement.
Thank you, Chairman Neal. Republicans would like to join with you in thanking Danielle for her devotion and hard work to this committee. We do wish she would have been a little more flexible in her interpretation of germaneness. Nonetheless, you've done a tremendous job for our committee. We're very grateful. We want to offer our best wishes as well. So today we are, as the chairman said, renewing our commitment to help moms and babies live healthy lives. As Republican leader of the Worker and Family Support Subcommittee, our dear colleague, Representative Jackie Wolorski, made a tremendous amount of progress working with Chairman Danny Davis to move this bipartisan bill forward. I, too, want to recognize Jackie's family here today, her remarkable husband, Dean, her vivacious mother, Mert, district staff, Sharon Christoffel, and someone we love seeing back here as well, our former colleague, Susan Brooks. We are just thrilled to have you here. We miss Jackie so much. We're so proud, though, to dedicate this bill and reauthorization to her. It wouldn't be possible without her hard work as a champion for children and families. And while the texts with Jackie continue, my last conversation with her was over Zoom on this bill as she was negotiating it with Chairman Davis. So I know how crucial, how critical this is to her. Mcv is a critical program. It supports vulnerable family and aims really to improve the health of moms and babies through pregnancy into the early years of a child's life. It is a bipartisan bill, and it reflects many of our Republican priorities, including increasing transparency about outcomes for families and targeting dollars to the neediest communities. The bill would gradually increase funding from $400 million a year to $800 million a year over a 5-year period, and introduces a state match as a way to expand the overall service capacity around the country. The principle here is simple. Federal government will invest where the states see value and invest themselves. It also ensures that new matching funds are allocated to states based on the number of kids under 5 below poverty. So funding goes where the greatest need exists. The bill increases transparency by creating a state-by-state outcomes dashboard so we can all see how these interventions are impacting families, and it also maintains the current focus on high evidence standards. Unlike many of our government programs, Mcv is evidence-based. So we know the real impact on families and children, and we're able to direct funding toward what works. The program has demonstrated success in supporting expecting families to increase healthy behaviors by coaching parents on child nutrition development, and then mitigating the risk factors to prevent child abuse and neglect. I'm glad we found common ground with our colleagues to get this bill done to provide stability for the program and the vulnerable families it serves. Today, we're also considering a collection of bipartisan policies that represent a step in the right direction in helping patients deal with mental health or substance use disorders. This bipartisan package of mental health bills will close gaps in mental health care, improve our current system to work better for patients, reduce physician burnout, protect consumers, and bring more openness into the system. Mental health has always been an important issue, but during the pandemic, I think all Americans saw an even greater mental health care challenge as a result of the COVID lockdowns and the lack of access to the care they needed. Seniors and patients with commercial insurance will benefit from these improvements. In order to address the spike in physician burnout we saw during the pandemic, we take action. Protect the mental health of frontline health workers by removing barriers to prevent greater access to wellness benefits. We provide greater flexibility so patients who need intensive treatment for mental health or substance abuse don't have to choose between continuing to work on getting the use disorder, but they're just woefully underutilized. The bill steps up outreach to ensure patients know what's available to them. And for better consumer protection transparency, we build on the improvements this committee led on banning surprise medical bills by requiring providers to inform health plans if they're accepting new patients. And victims of sexual assault will be protected from cost sharing associated with treatment exams related to their assault. Mr. Chairman, with that, I would like to yield to the ranking member of the Health Subcommittee for the remainder of my time, Mr. Buchanan.
The gentleman is recognized for 27 seconds.
27?
My bad. I apologize.
We'll give the gentleman some room.
Okay. Thank you. Thanks for yielding, Mr. Brady. Chairman Neal and Ranking Member Brady, I want to thank both of you and our colleagues on both sides of the aisle for working to find consensus on a bipartisan package of mental health bills reflected in 5 committee prints we are marking up today. Mental health issues affect millions of American families and communities across the country, so I'm pleased that we could get together on these common sense reforms. As the ranking member on the Health Subcommittee, I look forward to these legislative contributions from the Ways and Means Committee, serving as an important contribution to the future discussion the Congress has about mental health in the future of this session. The committee needs to have a strong voice and deliberation about mental health issues in the future, and our action today puts us on a path towards that. By advancing these measures, we ensure that the hard work on many of the committees have done get represented at a year-end legislative effort on this issue that'll make a big difference. Thank you, Mr. Chairman, and I yield back.
Thank you, Mr. Buchanan. I believe that Mr. Brady would like to engage in a colloquy.
Yes, thank you, Mr. Chairman. Look, I really appreciate our bipartisan work on these bills, and everyone who's worked on these packages should be very proud of their efforts. I know some of them will need budget offsets to move forward under the House rules and also to meet our committee's bipartisan commitment to fiscal responsibility. We've discussed this, but I just want to confirm that before both Mcv and the mental health policies go to the floor for a vote, we'll continue to work together to ensure they're enacted in a fiscally responsible way. We take the time to further absorb feedback and fine-tune the mental health policies ahead of what we hope will be bipartisan, bicameral, and successful negotiations.
Thank you. And my response has been okayed by Danielle Brown. I appreciate our partnership on these issues and agree that we fully intend for costs associated with this legislation to be offset in a mutually agreeable way when the legislation is enacted, and we will work with you to make sure that that is the case.
Thank you, Chairman.
Thank you. We now turn to the first order of business, H.R. 8876, the Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act of 2022. I want to yield my time to the champion of this issue, Mr. Davis from Illinois, who over many years has been a superb advocate on all of these issues, and we are grateful for the work that he did, and remind all that he attended Jackie's funeral, and he thought that there was a genuine partnership that had been developed, and how grateful we are for Danny Davis's work as well as Jackie's.
Thank you, Mr. Chairman. And let me also take the opportunity to commend you and Ranking Member Brady for your very passionate and congenial leadership that has gotten us to this point. For struggling families, home visiting is a life-changing experience. Research demonstrates that home visiting works. I have seen these successes in my home city of Chicago, parents and home visitors partnering to tackle big challenges in making children healthier and safer. Jackie Wolorski saw home visiting work in her district. Jackie was deeply committed to helping vulnerable children and families, and she was my partner in our committee's efforts to preserve and strengthen home visiting. Just a few weeks before she died, Jackie reached out to me to work on the reauthorization because Mcv was important to her and to us. Her tragic death robbed us all, and I so wish she were here to see us move forward with the work we led together. I want to welcome her husband, Dean, her mother, Mert, and her close friend, Sharon, all who are here representing her today, and we are delighted that Representative Brooks is here with us. Earlier this year, Jackie and I held a wonderful Worker and Family Support Subcommittee hearing where we heard compelling testimony, including from Erica Beck, a mother in my district who received home visiting services and captured the power of home visiting when she said, and I quote, "I know that our lives are changed forever and for the better because of Maya, our home visitor. She is helping me and Louis, my husband, help our kids succeed, and she's educating all of us." The Jackie Wolorski Mother and Child Home Visiting Reauthorization Act is critical legislation that would reauthorize the Maternal, Infant, and Early Childhood Home Visiting Program for 5 years. Over that 5 years, the bill would double our federal investment in evidence-based home visiting, bringing home visiting to more families and communities. And when I say double, I mean exactly that, double. This bill would more than double our investment in tribal communities, where so many communities need home visiting, but have been left out due to a lack of funding. It would invest in the critical home visiting workforce because it is the support and relationships that home visitors build with mothers, fathers, and children that make home visiting work. It would redouble our focus on targeted, intensive home visiting models, proven to help families in need while continuing to provide the right home visiting for the right family. It would continue our focus on the outcomes we achieve for families and create a new public outcomes dashboard so that Congress and the public can track results. Also, it would ensure that states and territories have reliable, predictable funding and rules so they can focus on helping more families thrive. And so I want to thank my colleagues on both sides of the aisle for their work on this legislation. I also thank the amazing subcommittee staff, Myrna Miller, Taylor Downs, Cheryl Vincent, and Andy Gradison, as well as Jackie's personal staffer, Marty Schultz. And I thank the dedicated stakeholders that worked closely with us to develop a reauthorization that builds on Mcv's success and strengthens it. Some of them are here with us today. I also ask unanimous consent to enter into the record this large number of letters that we have received from all across the country supporting this bill.
So ordered.
And Mr. Chairman, I urge all of my colleagues to support this strong bipartisan legislation that honors the commitment of our friend and colleague, Representative Jackie Wolorski, to help children and families throughout America. And I yield back.
Thank you, Mr. Davis. Now let me recognize the ranking member, Mr. Brady, for the purpose of an opening statement.
Thank you, Mr. Chairman. It's fitting that the opening statement for H.R. 8876, the Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act of 2022, be delivered by one of Jackie's closest friends and now the acting Republican leader of Subcommittee on Worker and Family Support. I yield to Dr. Winstrup.
Well, thank you, Mr. Chairman. Thank you, Mr. Brady. Thank you for bringing up the Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act of 2022. I want to take a moment to reflect on what we're doing here today. This markup serves as an opportunity to celebrate and remember our dear colleague and friend, Jackie Wolorski. She was my battle buddy, indeed, my very dear friend. And I'm honored to be able to work to continue her work. And I want to recognize her husband, Dean, my friend, Dean, and her dear mother, Mert, our friend, Susan Brooks, our friend, Sharon, and really all of Jackie's staff, former staff that are here today. Dean, I may feel a need to send a text to Jackie during this, as you know. I'm proud to help lead our efforts here to reauthorize and grow evidence-based home visiting programs and help more moms and babies. I can't think of a better way to honor my friend Jackie Wolorski than seeing this through. Today is an opportunity to recognize Jackie's legacy and what she supported, believed in, and advocated for, improving outcomes for vulnerable families and children, which really was her life's work all along. As ranking member of the Worker and Family Support Subcommittee, Jackie made a tremendous amount of progress working with Representative Davis on this bill prior to her passing. The bill includes many of the areas she felt strongly about, including increasing transparency about outcomes for families and targeting dollars to the neediest communities. I'm glad we were able to find common ground with our colleagues to get this bill done, to provide stability for the program and the vulnerable families that it serves. As a physician, I'm very familiar with the evidence-based efforts of in-home support for both new parents and children, and I really value the program's focus on preventative health. Last month, I met with young moms in Ohio who went through the Nurse-Family Partnership. I've seen firsthand how the program helps maternal and child health, family safety and stability, child development, and readiness for school. It's a broad range. To look at these people in the eyes and hear them tell me, quote, "I don't think my child would be healthy without this program. Home visiting made all the difference in the world for me and my now healthy child." To hear from a young mom, to know that she's in a better place and on a better path, reminded me of the good work that this program does and showed me the value of investing in a program that we know works. Our bipartisan legislation reauthorizes Mcv, as we call it, for 5 years and will serve moms and babies by growing the capacity of the program in partnership with states. First, by phasing in a state match to vulnerable populations, we will expand the reach of evidence-based home visiting programs across the country by adding $174 million in new state funding. Second, we target funds to families in poverty by directing 3/4 of additional Mcv funding based on the number of children under 5 in poverty in each state. Third, the bill improves outcomes reporting so more people will have visibility into the good work being done by home visitors. HHS will implement a state outcomes dashboard so we have more transparency on program performance measures and clinical indicators to show actual impact on families. Outcomes and transparency, two things that were very important to Jackie in her efforts. Lastly, we apply lessons learned from the pandemic and allow virtual visits to continue on a limited basis while maintaining Mcv's commitment to in-person visits and high evidence standards. So I'm proud to support this legislation, named in honor of my friend, Representative Jackie Wolorski. Jackie was a devoted public servant who was a champion of this bill, of Mcv, and especially the Healthy Families Indiana program she visited within her district. I urge my colleagues to support this bill. I'm humbled to be Jackie's voice here today to help carry out her great works. And I yield back.
Thank the gentleman. The committee will now proceed to consideration of H.R. 8876. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute which was distributed in advance, along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. I will now turn to the very capable staff director, Morna Miller, for the Subcommittee on Worker and Family Support to provide the technical description of the amendment in the nature of a substitute with an emphasis on changes made since notice. I ask members to hold their questions until after her presentation. Ms. Miller.
Thank you, Mr. Chairman. H.R. 8876, the Jackie Wolorski Maternal and Child Health Home Visiting Reauthorization Act, would reauthorize the federal home visiting program for 5 years and provide funding to states and territories under a statutory formula. Total federal funding would rise to $500 million in fiscal year 2023 and reach $800 million by fiscal year 2027. The additional funding includes a $100 million increase in base funding, which does not require a match, starting in fiscal year 2023, and additional federal funding, which begins in fiscal year 2024, which would require a 25% state or territory contribution and would reach $300 million by 2027. The bill would also reserve and increase funding for tribal home visiting, workforce support, retention and case management, technical assistance, research, evaluation, and program administration. It would require publication of relevant data, including an outcome dashboard, and clarify and update rules and administrative procedures to ensure that the program is both efficient and effective. The amendment in the nature of a substitute makes a technical correction to the introduced bill, replacing a reference to state, which is defined in the law as a state or territorial government, with eligible entity, which it also includes states or territories where the Mcv program is administered by a nonprofit organization. That concludes my walkthrough. I'd be happy to answer any technical questions that members of the committee have about the amendment in the nature of a substitute.
Thank you, Ms. Miller. Are there any questions about the amendment in the nature of a substitute? The gentleman from Texas, Mr. Doggett, is recognized.
Thank you very much. In asking questions, I would first want to join colleagues in expressing our appreciation for the service of Congresswoman Wolorski, and I think it's so appropriate that her name will now be written permanently into the statute books in United States Code associated with this program, and we honor her husband and her mother who are here on this matter. With reference to the substitute, the change that you just mentioned with regard to eligible entities, if you have a poor state, say Mississippi, and it concludes that it cannot make the match on this new fund, what happens to those funds?
Under the amendment to the nature of a substitute, if a state or eligible entity does not provide the full allocation of non-federal funds, which are funds that are obligated in that state for evidence-based home visiting that is targeted at individual family outcomes, then those funds go into a pool for states and eligible entities that have said that they would be interested in additional funding, and those states and eligible entities then have the opportunity to provide a 25% match by reporting state expenditures or nonprofit expenditures on home visiting, and to draw down those funds, and then those funds would be added to that eligible entity's allocation for the following year. So for example, if over the course of the full year 2024, an eligible entity was not able to report to the Secretary an expenditure of non-federal funds sufficient to draw down the full allocation, then the remainder would be reallocated in the following fiscal year.
Does that mean, in essence, that if Mississippi can't afford to do it for one reason or another, that the money could go to California or New York or another state, but not to Mississippi.
That's correct.
And the change that you just referenced in the substitute does not affect that when you refer to other eligible entities.
That does not. There's a provision in the underlying Mcv law that allows for a situation where a state chooses not to administer the program at all, and there are 3 states that have made that choice. And so in those cases, the entire program is administered by a nonprofit entity, and so the amendment of the nature of a substitute is to, and so in general, the statute refers to eligible entities because we treat those administering nonprofits as if they were states for the purpose.
Well, in my example, then, if there were such an entity in Mississippi and it could make the match, could it access the funds instead of having them go to California?
So so for example, in your example of the state of Mississippi, they would have a couple of different options for drawing down their full allocation. One obviously would be for the state to appropriate funding, which was obligated to provide evidence-based home visiting services. Another would be that if the state identified non-federal expenditures within the state that met the statutory test of affecting outcomes and also of meeting the Mcv evidence test, that they would have the ability to report those expenditures, and they would have the ability to report those expenditures to the secretary. There are also situations, I don't know about Mississippi specifically, but in a number of states, they have evidence-based home visiting programs that are outside of their Mcv program and are not part of their Mcv maintenance of effort requirement. And in those cases, if the state expenditures met all of the statutory tests of evidence-based, targeted, and intensive, intended to expect, they would, and were reported to the secretary, they would count.
And how much does the bill cost?
The Congressional Budget Office has preliminarily estimated the effect of the bill as $3.07 billion over 10 years.
After much work, when were you first able to agree with your Republican counterpart on the final draft?
I'm sorry?
When were you first able to get agreement with your Republican counterpart on the final draft of this proposal?
So we have been working on the substance of the bill together for several months. We finalized we made the final technical corrections to the bill on Monday after a final review by HHS. And
I see my time is expiring. I would just note that I believe this program originates with the work of our former colleague, Jim McDermott, who headed the subcommittee at the time it first came up, Senator Ted Kennedy in the Senate, and was part of the Affordable Care Act, was it not? And you were working on that at that time from the Budget Committee along with Nick Gwynn from our staff here on the committee.
Mcv was enacted as part of the Affordable Care Act.
Thank you. Thank you, Mr. Chairman.
Are there any other questions about the amendment in the nature of a substitute? Hearing none, we will proceed to the next phase, and that is, is there a member here who would like to move to strike the last word? The gentleman from Nebraska, Mr. Smith, is recognized to strike the last word.
Thank you, Mr. Chairman, and to our colleagues, certainly welcome to Jackie's family and friends. It's great to have you. It's certainly appropriate. You know, I think it is so important that we point out that we can agree on a process like this and a program like this that's evidence-based, where we can identify the needs before money is spent. The money is spent, and then we make sure the money was spent where it was intended to be spent. And I just cannot say enough how important that is, that we're dealing with peer-reviewed information, comparative research, and I think it's what taxpayers would want us to do in many areas. And so I think it's important to note that I believe this started as a pilot project from President Bush 43, and it's been reauthorized since then. I was proud to be a leader on the Human Resources Subcommittee, the chairman of the subcommittee when we reauthorized it the last time, and it shows that we can get some good work done here in a bipartisan fashion and to help folks in need in a very identifiable way, an effective way, and a way that helps folks prepare for the future. Thank you. I yield back.
Thank the gentleman. Are there other members who would like to move to strike the last word? The gentleman from Oregon, Mr. Blumenauer, is recognized to strike the last word.
Yeah, I'm going to veer a little bit off script, but I appreciate the reflections on our colleague and her many contributions. I just want to note one. She also was a lead member of an effort to deal with sanitation and water for poor people around the world. It's not on point for the committee, but she invested time and energy in something that people really don't pay much attention to. Half the people who are sick today in the world are sick because of sanitation and water problems, and Jackie realized that and was willing to invest time and energy to try and put the focus on that, and it's just something that I would like to acknowledge. Mr. LaHood understands that very well.
Are there other members who would like to strike the last word? The gentleman from Florida, Mr. Buchanan, is recognized to strike the last word.
Thank you, Mr. Chairman. I appreciate the committee's consideration of this bill today in honor of our late colleague, Jackie. She was a tireless advocate for family and children. I am pleased to be able to honor her legacy in this way. I also understand that her husband, Dean, and her mother are here today, are in the audience, and I'd like to extend a welcome to them. I strongly encourage my colleagues to support this bill. Mcv is already a successful, evidence-based program that has improved itself with mothers and their babies. The critical Mcv tie between funds and programs that demonstrate results means taxpayer dollars are put to work for the benefits of those who need it. What's more, this bill builds on the success of implementing important safeguards like codifying the formula used to designate funding from state to state rather than leaving it to HHS discretion. This bill will also create a state match and ensure funds are targeted for children under 5 in poverty. Republicans and Democrats, unfortunately, don't agree on a lot, but this is something we can agree on together in terms of the importance of strong, healthy families. Thank you, and I yield back.
Thank the gentleman. Are there other members who would like to move to strike the last word? Mr. Pasquale, the gentleman from New Jersey, is recognized to strike the last word.
Thank you, Mr. Chairman. Mr. Chairman, Jackie Wolorski was a warrior. And I go back the last 25 years of Republicans and Democrats who worked on the issue of mental health. They were warriors. They were looked at skeptically 25 years ago, for whatever reason. But they pursued it. The amount of energy that went into mental health issues is fantastic. As fantastic as Jackie's family being here today. What a breath of fresh air in this room. And we will remember her. This bill will continue and expand home visiting programs. They are essential to children and families. Our bill provides the first increase in every state's base funding since the program was first implemented. Throughout the pandemic, New Jersey home visiting programs provided a lifeline to pregnant women and families with infants and toddlers. The pandemic was isolating for pregnant and postpartum parents and newborns. But New Jersey home visitors provided emotional support, access to food and diapers, and ensured baby checkups continued. Jalen, a teenage mom from Teaneck, New Jersey, enrolled in the Bergen County Healthy Families Program in 2021 after giving birth to her son. Pregnancy and parenting are among the most common reasons for teens to leave school. But Jalen's home visitor, Catherine, helped Jalen stay in school, and it worked. She graduated Jalen this past spring. Now she is at Bergen County Community College, studying in criminal justice. Catherine also helped Jalen address the depression and isolation that new parents often face. Broken arm, broken heart. We are at a point of equity where we've never been before. Hallelujah. It's people like Jackie and Danny that got us here. Catherine helped Jalen address that depression and isolation. Home visitors in New Jersey serve about 7,000 families annually across my state. The increase in funding in this package will help home visitors in New Jersey and across America serve more of the families in need. Again, I want to thank Chairman Neal, Chairman Brady, Mr. Davis, our chairman, and of course the late ranking member, Wolorski. She will not be forgotten, and we're going to miss her. Thank you, Mr. Chairman.
Thank the gentleman for his good work and comments as well. And also, since we were talking about the lineage of mental health support, let us not forget Pat Kennedy and Jim Ramstead. They were the ones that successfully sought mental health parity in terms of insurance requirements. With that, let me recognize individuals in the order in which they sought that recognition. And the gentleman from Pennsylvania, Mr. Schmucker, is recognized to strike the last word.
Thank you, Mr. Chairman. Thanks for bringing up this bill. I'm very pleased to support this bill and was happy to be an original co-sponsor of the bill as well. Obviously, we're all sad Jackie's not here with her. As a member of the subcommittee, had many discussions with her about how we can best help the most vulnerable among us. And so I know that today, in passing this bill, we're honoring her legacy and we're continuing her work, and we're so pleased to have her family and those who loved her with us here today. The Mcv Program truly is an evidence-based voluntary service to vulnerable families, pregnant moms, and babies. We've seen in my community, the district that I represent, the impact of this program, having a nurse, a social worker, or an early childhood educator visit families in their homes during the first years of a child's life provides a multitude of benefits. And we've measured the results of the Mcv Program and found that these services improve maternal and newborn health, they reduce child abuse and neglect, improve family economic self-sufficiency, and improve school readiness. In Pennsylvania, state district I represent, the program awardees have visited nearly 3,000 households, of which roughly 70% were low income. Additionally, almost 90% of mothers enrolled in home visiting received a visit from a healthcare provider within 8 weeks of delivering their baby. Much of this program is carried out by the nurse-family partnership in the two counties that I represent in Pennsylvania, York and Lancaster. It's an organization that has operated for some time. Just recently had the opportunity, as I've done multiple times, but just recently visited the Nurse Family Partnership in Lancaster County and saw again, spoke to mothers and saw again the impact of this program on the mothers and their children. The nurses there help these mothers learn about child nutrition and development and provide referrals for health care, job training, and child care. So I'm so grateful for the important work that Nurse Family Partnerships does in my community. Mcv is just one example of how we can serve both moms and children through pro-family policies that empower families to work hard and be self-sustaining. So I'm hopeful that this legislation will build upon the important work that has already been done, and I'm very, very proud to support this bill. So thank you, Mr. Chairman. I yield back.
Thank the gentleman. Let me recognize the gentlelady from Wisconsin, Ms. Moore, to strike the last word.
Thank you so much. Move to strike the last word. Thank you so much, Mr. Chairman, and thank you and the ranking member for convening this meeting to pass this very important bill. I just want to say, before I comment on this bill, that before I joined the committee, Mr. Chairman, I had the pleasure of meeting Jackie Wolorski because of her tremendous work on food insecurity and doing that work with Mr. McGovern. It's very, very consistent with her work as a missionary and her work on this mission, indeed. I'm so happy that we're coming together. I'm so happy that she worked on this, because this is a program which has been tremendously underfunded. I'm going through my so-called talking points here because I don't want to repeat things that others have said. But I do know that in Wisconsin, in fiscal year 2020, there were 33 home visiting programs operating in 40 of the state's 72 counties, serving over 2,000 families. But indeed, I had received a letter from our governor indicating that only about 3 to 5% of eligible families could be served at the current existing funding levels. And in our state, what that really meant was moving resources out of very successful programs and putting them in areas where there was a dearth of services, and thus depriving healthy programs of their ability to provide these services. Again, for our tribal communities, and I am from the state of Wisconsin, it was very, very important that this bill provide higher resources in this bill. And so the tribal communities will see their funding rise under the bill from $12 million in fiscal year 2022 to $48 million fiscal year 2027. That is tremendous. Mr. Chairman, I just want to say that one of the reasons that I love serving on this subcommittee, and I insisted on serving on Ways and Means Committee, and my very first pick was to serve on this subcommittee, Families and Children, because so much of my lived experience has motivated me to be on this committee. And one of those lived experiences has been with a home visiting nurse. I gave birth at age 18. I had never babysat for an infant, and I had no idea how to even put a diaper on a child. And my first effort, I stuck my poor baby trying to get a diaper on her, and the visiting nurse showed me, this is the days before Pampers people, taught me how to put a diaper on. And so I am so happy that the Jackie Wolorski home visiting program is going to receive this increase in its base funding so that no families will be deprived of this asset, which really really stops morbidity and mortality, not only of the babies, but women as well. I'm so pleased to see the provisions providing for mental health, because indeed, postpartum depression is a real thing as parents feel the overwhelming responsibility of a brand new infant. And I want to thank Dean, her husband, and her mom for sharing this moment with us. And with that, Mr. Chairman, I will yield back the balance of my time.
Thank the gentlelady for her good comments, and also a reminder, as she affirmed that when she said that the Ways and Means Committee was your first choice, I think it's fair to say it's the first choice of 90% of the members who come to Congress. With that, let me recognize the gentleman from Kansas, Mr. Estes, to strike the last word.
Well, thank you, Mr. Chairman. You know, a stable family is essential for childhood development. It's the security of a stable family that allows children to grow and learn. But stable families are becoming harder to find in our society today. An alarming number of children are raised in fractured families, with the share of single-parent families tripling since 1965. It's been well established by research that children raised by married parents do better in pretty much every measured outcome. With this being the case, it's essential for those of us in Congress to make sure that we work to put forward pro-family policies that help address this family crisis. Our goal should be to help encourage stable families which are not dependent on child welfare, and we know that strong families will make a strong America. The Maternal, Infant, and Early Childhood Home Visiting Program, Mcv, fits into this basket. At its core, the program helps to keep families strong and together. It's an evidence-based program that supports pregnant women and parents with young children, helps improve overall maternal and child health outcomes. This legislation reauthorizes a historical bipartisan program whose whole purpose is to ensure that mothers and children do not fall through the cracks. Families will be able to meet where they are and connect to a host of support systems, whether it be referrals to specialty care for their children or mental health supports for the parent. This program will help continue to support families in all of our districts. One of the most beneficial parts of the program is that can help connect mothers to services and support when they are pregnant, setting them up for long-term success. I also think it's important that this reauthorization requires a new annual report to Congress, which will allow better oversight and help us identify areas for improvement in the future. And after all, we want to make sure every program provides the best services that we can. With that, I yield back, Mr. Chairman.
Thank the gentleman. Let me recognize the gentlelady from California, Ms. Chu, to strike the last word.
Mr. Chair, I move to strike the last
The
word.
gentlelady is recognized.
I want to say that it was an honor to work closely with Representative Wolorski throughout my time in Congress. On this committee, in particular, she and I worked together to co-lead bills on breast cancer equity and on medical nutrition therapy for those in the Medicare program with eating disorders. I also had the pleasure of co-chairing the Integrative Health and Wellness Caucus with her to help educate members of Congress in the various ways integrative health can help support our traditional medical system and lead to improved care for patients. In our last meeting as chairs of the caucus, in fact, she talked about how she had just taken up yoga and what a transformational impact it had on her life and mental health. In our time working together, I was consistently struck by her dedication to her district and deep desire to find ways to make our healthcare system work for everyone. I want to offer my condolences to her family in the room today, and I want to say thank you for sharing her dedication and service to the American people and her constituents especially. Well, turning to the bill before us today, I'd like to express my support for the Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act, which reauthorizes the Maternal, Infant, and Early Childhood Home Visiting Program, or McV, and increases federal investments into the program over 5 years. McV targets high-risk families who most likely could benefit from intensive home visiting services through trained professionals, oftentimes nurses, social workers, or parent educators. And it helps parents acquire the skills to promote their children's development. McV is a vital source of support for young mothers and working families and has a bipartisan reputation of being the gold standard for evidence-based policymaking. Despite the resounding success of this program, funding has remained flat over the past decade, limiting its reach to less than 5% of eligible families each year. In Los Angeles County, where my district is located, 37,000 families were served through evidence-based home visiting models in 2021, but an estimated 750,000 more expecting and parenting families with children under 6 years old were eligible for home visiting services during the same year, but were unable to receive them. That's why I'm so excited to see the additional investments in this year's reauthorization in recognition of the gap in our capacity to serve those in need. In addition, home visiting programs frequently identify recruitment, retention, and high turnover of home visitors as one of their key challenges to adequately serving families. Low wages and poor benefits for the field is a main driver of these challenges, and additional funding is needed to address workforce challenges and provide competitive wages to these vital providers, the overwhelming majority of whom are women. Expanded resources would address critical workforce challenges while providing competitive wages to these vital providers. I look forward to working with this committee to move this bill forward, and I yield back.
Thank the gentlelady. Let me recognize the gentleman from Pennsylvania, Mr. Kelly, to strike the last word.
Thank you, Mr. Chairman. There's an awful lot we're talking about today, but it really comes down to the fact that we had a colleague who's no longer with us, who this bill is being named in honor of. And Dean, good to see you. Mert, good to see you. Susan, always good to see you. I'm reminded often times like this of there's a line, I think, in the musical Annie, at the end when Annie's leaving the orphanage, she says, "How lucky am I to have had something that's so hard to say goodbye to?" And I would change it to how blessed we are to have someone to work with. This makes it so hard to say goodbye to. This bill is about Jackie Wolorski and her entire purpose for being in here. In fact, her entire life was in service to others. And this is not a Republican or Democrat issue. This is just more or less an American issue. That's what Americans do best. They take care of each other, and they take care of other places all around the globe when there is a need for it. So, Dean, you being here today and in the memory of Jackie is just incredible. We used to have some conversations about South Bend. I was only there for 4 years. She spent her whole life there. As much as we mourn the loss of Jackie, what if there had never been a Jackie Wolorski? So, Mert, thank you for your role in bringing her into this world, and for the opportunities we had to serve with her in meaningful ways. I don't think that any time Jackie ever spent was wasted. Her whole life was dedicated to helping others, as I said earlier. So to be here today and be able to talk on this, but more importantly to talk about Jackie, as much as I mourn her loss, I am so thankful for her existence. What would this have been like if Jackie Wolorski had never served here? What would this be like for this world if Jackie Wolorski had never been born? What would we have missed that now we can look back on so fondly and say, you know what, that was time well spent here. And I know for most of us, I look forward to the time we're reunited and would have a chance to say hello to her again and give her an embrace. And we can probably talk about the Fighting Irish and what they've done and what they haven't done, because a lot of our conversations, again, are centered around South Bend. But thank you so much for this committee for doing this, because there are very few times that we can actually honor somebody in this way with a piece of legislation that just makes so much sense for the future of America. I know we talk about children. They're 25% of our population, but they're 100% of our future. If we can't protect that asset, what are we doing? So again, Dean, good to see you, Mert. So good to see you. And again, my memories are the best of your wife and your daughter, and thank God she was here. I hated to see her leave. She left way too soon. But I look forward to being joined again sometime in the future. Thanks so much, and I yield back.
Thank the gentleman. Let me recognize the gentlelady from Alabama, Ms. Sewell, to strike the last word.
Thank you, Mr. Chairman. I wish to join with my colleagues in expressing my sincere condolences on the loss of our dear colleague and friend, Jackie Wolorski. When I think of Jackie, I think of her beautiful smile. Her smile would light up any room that she walked into. I'm proud to say that she and I shared a love for beautiful jackets, and in fact, we own 2 of the same jackets, and we would often huddle on the House floor the day before the Ways and Means hearings, so we would make sure we wouldn't wear that jacket on that same day. Jackie was full of life and full of love, and she shared that love with so many of us. I want you to know that I considered her to be a kindred spirit and a dear, dear friend, and I will miss her terribly. I think it's perfect that we are doing this bipartisan legislation to honor her memory and her name and her life's work. When I think of the importance of the Mcv program, I think about my district. My district is my home district. I grew up in the district that I represent. And over 1,800 pregnant women, new mothers, and families throughout my district and the state of Alabama receive services from the Mcv program. The Home Instruction for Parents of Preschool Youngsters program in the state of Alabama, HIPPY, in particular, has been a transformative program that has really reshaped early childhood care in my district and in this nation. The communities I represent in Dallas County, Lowndes County, Montgomery, Perry, and Wilcox County have seen the benefits and results of the Mcv funding, and I am so proud that we are increasing that funding in her name. I applaud this measure, Mr. Chairman, and would proudly vote in favor of this legislation which bears our beloved colleague's name. May she rest in power in knowing that her memory, her legacy will live on through all of us. Thank you.
Thank the gentlelady. Let me recognize the gentleman from Oklahoma, Mr. Hearn, to strike the last word.
Mr. Chairman, I'd like to strike the last word.
Gentleman is recognized.
I first want to acknowledge the hard work and dedication our friend, our dear, dear friend, Jackie, poured into the Worker and Family Support Subcommittee, this authorization, and her constituents. I'm glad that Jackie's husband, Dean, are here, and Mert. So good to see you. Growing up, I watched my mom and stepdad rely on the government for everything. I saw how the reliance on the government became unhealthy, and instead of helping my family out of poverty, it dragged them down. With that experience of mine, it's been my mission to filter through these programs to find the helpful and effective ones and eliminate the waste. Simply throwing money at our problems is never a solution, which is why I'm glad increased accountability and measuring outcomes are included in this reauthorization. Evidence-based programs that improve maternal, infant, and early childhood health and provide opportunities to graduate off of the government assistance that is worth investing in. As an example, in 1996, Congress passed a bill that tightened rules around welfare eligibility, making benefits conditional on work. While progressives claimed that wages will go down, families will fracture, and millions of children will be made more miserable, the opposite happened. In fact, since then, child poverty has fallen 59%, and by the same degree among children who are white, black, Hispanic, and Asian, living with one parent or two, and in Native or immigrant households. With these accountability measures in place, I look forward to seeing less children in poverty, more resources available to mothers and families, and better outcomes than before. Thank you, Mr. Chairman. I yield back.
Thank the gentleman. Let me recognize the gentleman from Texas, Mr. Doggett, to strike the last word.
Thank you very much, Mr. Chairman. I think it's very appropriate that a program that was initiated by Ted Kennedy and Jim McDermott out of the Affordable Care Act will now bear the name of Jackie Wolorski, because social service programs that are evidence-based and effective like Mcv can only be sustained if they have strong bipartisan support, as we're seeing here today. Home visiting is about supporting children and parents during the most crucial years of their brain development. We know that a child's brain doubles in size in the first year and keeps growing to about 80% of adult size by age 3 and 90% by age 5. Home visiting helps parents be the parents that they really want to be. In Austin and San Antonio, Texas, we have a program called Any Baby Can, and it lives up to its name, often working with parents who have babies who face big challenges with disabilities. One example of this program, headed very effectively by Veranda Durden, is a woman named Alexandra. She was a single mom of 3 in Austin, and she came to Any Baby Can about 15 years ago. She received mental health counseling after the birth of her son and help from the Early Childhood Intervention Program when her son faced developmental delays. When her family hit hard times, she was also provided with financial assistance through Any Baby Can's Family Support Services. All of these services and programs were funded with help from Mcv. With the assistance of the program, parents are able to learn more effective parenting skills and get connected to resources in the community that best meet the needs of their child and their family. As with so many other social service and education programs, Texas unfortunately has the very troubling distinction of having more children in poverty than any state in America. Over 12% of Texas children under 5 fall under the poverty line. State obstructions of many programs interfere with being able to resolve their needs. So often in Texas, the safety net is more whole than net. In that circumstance, it is programs like that at Any Baby Can, the United Way, St. David's Foundation in Austin, that offer dedicated and compassionate assistance under very challenging circumstances. We have more than 16,000 babies born in Travis County, that's Austin, each year, and an estimated 95% of them had some health needs within the first few weeks of being home. Families who receive support from Mcv are 34% less likely to need infant emergency care, and mothers are 28% less likely to report symptoms of maternal anxiety. This reauthorization will ensure that more of these babies and their parents receive the support that they need by doubling the funding for Mcv, expanding the numbers of families served, and better supporting the workforce. Though, as our colleague, Ms. Chu, just indicated, a very significant number of families, even with the doubling of this funding, will still not be served. And this legislation allows the use of the first time of virtual home visiting, which is especially helpful in rural parts of our country and traffic-ridden cities. These funds come at a very critical time for families after the pandemic, which had such a big impact on families and their children. I believe that it represents a significant advance and fully support this legislation. I yield back.
Thank the gentleman. Let me recognize the gentlelady from West Virginia, Ms. Miller, to strike the last word.
I move to strike the last word.
Gentlelady is recognized.
Thank you so much, Chairman Neal and Ranking Member Brady. I rise today in support of the Jackie Wolorski Maternal and Child Home Visiting Act. Mcv is an evidence-based program that supports vulnerable pregnant women, parents with young children, to help mitigate the risk factors for maternal and infant mortality and to improve overall maternal and child health outcomes. It supports voluntary home visiting services for families with young children who reside in communities that have concentrations of poor child health and other risk indicators. Programs like these are essential and deliver meaningful results that strengthen our families and our communities. In West Virginia, the Mcv program has made over 21,000 home visits, served over 1,500 families, and impacted over 1,900 children. The program not only supports our vulnerable pregnant women, it comes alongside the parents with young children to ensure that they all have the resources they need to raise their children. I also want to take a moment to commemorate my dear friend and colleague, Jackie Wolorski, who this bill is named after. Jackie was my mentor when I first came to Congress, and she quickly became my friend. She found it kind of ironic that I'm Carol Miller from West Virginia, but I stem from the Leeper family, who was one of the founding families of South Bend, Indiana. We shared many meals together, good conversations about her fashionable jackets, about her love being on the water with Dean, and her office was even right across the hall from my own in Cannon. It was my pleasure to serve alongside her on the Worker and Family Support Subcommittee. Her leadership and her passion for these issues are reflected in this bipartisan bill, and I commend our committee for coming together to honor her memory. Thank you all for being here today.
Thank the gentlelady. Let me recognize the gentleman from New York, Mr. Swazi, to strike the last word.
Thank you, Mr. Chairman. I just wanted to recognize that I'm inspired by the spirit that has descended upon this hearing room today, the spirit of bipartisanship, the balance that we see between the genuine desire to serve people, to help people, to make their lives better, and legitimate concerns about accountability and the good running of an effective running of government. I've mentioned to some of my colleagues before that my father was born in Italy, and my grandfather used to give speeches at the family weddings, and he would say, "Che cosa matrimonio?" What is marriage? He said, it's a long journey with a lot of ups and downs. But that's okay, because in life, non ci sono rose senza spine. You can't have a rose without the thorns. And certainly today we mourn the thorns that the Wolorski family is feeling. We know that we can't imagine how our mother feels, how her husband and family feel, her friends feel. and they've suffered thorns in their lives. But today we celebrate the roses of life when we get good people on both sides of the aisle coming together as Democrats and Republicans in the spirit of Jackie Wolorski to try and serve people in legitimate ways, to try and make the world a better place to live. And I hope that this spirit will continue to inspire my colleagues as we move forward together to try and do the good work of the American people. I yield back.
Thank the gentleman. Let me recognize the gentleman from Missouri, Mr. Smith, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word.
Gentleman is recognized.
I'm proud of this committee to be coming together on a good bipartisan common sense legislation as we honor our dear friend and colleague, Miss Jackie. I would like to also recognize Jackie's husband and mother, Dean and Martha. Thank you so much for being here. Just know that your daughter made such a huge impact in every one of our lives, and we love her. I also want to highlight that just a little bit earlier, it was mentioned where this program came from. This program came from a pilot project started by Bush 43. And so that's pretty special in itself. The Maternal, Infant, and Early Childhood Home Visiting Program, Mcv, is an example of what can happen when the federal government does its job right. This is an evidence-based program that protects the well-being of our nation's children and families. It uses its funding responsibly. It leads to results, and it makes a world of difference for our most vulnerable families. For the people I represent in Southeast Missouri, Mcv is a godsend. 4 counties in my district, Butler, Dunklin, Pemiscot, and Ripley, actively participate in this program. In fiscal year 21, the Show Me State received nearly $4 million to implement Mcv, leading to over 500 households benefiting from the program and over 10,000 home visits performed. The results speak for themselves. We had over 99% of the caregivers enrolled in home visiting screened for domestic violence in the first 6 months of enrollment, making sure homes are safe havens for our children to grow. Home visits also showed that 92% of infants enrolled in Mcv were put to bed safely, reducing the number of tragic infant mortalities that devastate families. These are life-changing outcomes that lead to healthy, safe, and happy homes. And they are thanks in large part to this program. Mcv works for Missourians. It is truly vital that Congress reauthorize this program in our friend Jackie's honor. Thank you, and I yield back.
Thank the gentleman. Let me recognize the gentleman from North Carolina, Dr. Murphy, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last
Gentleman
word.
is recognized.
I'm not going to repeat all the wonderful things that people have said today because there are so many wonderful things about this program. We share your loss. We share your loss. Jackie was a tremendous lady that I knew for just, unfortunately, a very, very short time. I want to bring up what I think really are 2 issues about this bill. First of all, as my colleague, Mr. Estes stated, we've had 3 times the number of families that need this program since 1965. So I think it's all a program that we wish didn't exist, didn't need to exist, but we're all very, very glad that it does exist. You know, sadly, I think some of the government policies that have been enacted have created much more of a problem, but as we say, it is what it is. And so I'm glad that, as my friend Mr. Smith just stated, this is when government gets it right. But even to more of a point, this is an investment. I've been in these homes when I was in the state legislature. We helped deal with this program. I've been in these homes, and these young 16 and 18-year-old single mothers desperately, desperately need our help. We wish the fathers were around, and I think personally this is the greatest and saddest part of our society today is the outlandish amount of fatherlessness that we have in this nation. That said, This is where these young mothers can come in and truly have the help that they need, as it's an investment for their children and for these young mothers. And this is where money of the government actually is well spent. These are not handouts. These are hand-ups, and this is what government is supposed to do. So again, thank you, Mr. Chairman, and I will yield back.
Thank the gentleman. I think we are now prepared to move to the amendment stage. Are there any amendments to the amendment in the nature of a substitute?
Mr. Chairman, I have an amendment at the
The
desk.
gentleman from Ohio, Dr. Winstrup, is recognized to offer an amendment.
Thank you, Mr. Chairman. The Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act of 2022 includes a 2% set aside for strengthening the home visiting workforce and established base practices for effective case management. My amendment would direct HHS to reserve a portion of this set aside to establish a new technical assistance center named after Congresswoman Wolorski called the Jackie Wolorski Center for Evidence-Based Case Management. This technical assistance center would focus on evaluating best practices for effective case management for use by states implementing Mcv to strengthen the program's impact on improving outcomes for vulnerable families and children. My friend Jackie believed in the value of a human connection. She believed home visitors and case managers can make a bigger difference in a young mother's life than just sending a government check. Jackie believed in evaluating programs, finding out what works, and investing in programs that we know will be effective. A strength of the Mcv program is its reliance on home visiting and meaningful in-person interactions between families and qualified, well-trained home visitors. Home visitors need a wide-ranging skill set and are responsible for case management defined broadly as everything from family engagement strategies, understanding clinical indicators of maternal depression, monitoring child development milestones, screening for domestic violence and child abuse, and establishing linkages with critical referral services that meet the unique needs of each family. As ranking member of the Ways and Means Worker and Family Support Subcommittee, Jackie Wolorski believes strongly the Mcv program is a high mark and example of successful, results-driven, evidence-based policymaking. During a subcommittee hearing we held in March of this year, Representative Wolorski said, "Connecting families in need with compassionate human support is proven to uplift families and change lives. Through the voluntary home visiting services offered by Mcv managers are able to provide tools to children and families during critical early years that will set up our kids for future success." I think this center is exactly the type of legacy that we should leave in Jackie's honor. I urge my colleagues to support this amendment, and with that, Mr. Chairman, I yield back.
Thank the gentleman. The chair would note that we have not reserved a point of order on our side on this amendment because we think it's a good one. I think it adds to the importance of the moment, and it is a sound addition to the bill, and I strongly would support the gentleman's recommendation.
Mr. Chairman.
Dr. Davis is recognized.
Thank you, Mr. Chairman. I thank my colleague, Dr. Winstrup, for offering this amendment to memorialize our colleague, Jackie Wolorski, and one of her passions, the power of effective case management. Congresswoman Wolorski knew how important home visitors are to the families they work with and how many different challenges those families face. Jackie was passionate about supporting the case management, home visitors, the work that they do to help families address all of their challenges in a way that makes sense. She often spoke about case management and how case management can improve social service outcomes, helping keep vulnerable people from falling through the cracks. By providing for this technical assistance center, we ensure that we will keep developing new and better ways to do this work and will make these improvements available to states, territories, tribes, and home visitors themselves. I am indeed happy and delighted to accept this amendment and urge its passage.
Thank the gentleman. Let me recognize the gentlelady from the Virgin Islands on the amendment, Ms. Plaskett.
Thank you so much. I just want to say how enthused I am about this legislation and the work that's been done to bring us to where we are. Importantly, for U.S. territories like my district, we have doubled down on a formula in which HHS must use the most recent poverty data that exists for each state and or territory. One of the ways that territories have been underfunded and underincluded and in the home visiting funds is because it has been based in the past by HRSA on poverty data that was inapplicable to territories because federal government had persistently declined to extend data estimates to the territories, such as the American Community Survey or the Small Area Income and Poverty estimates of the census. This won't be able to occur any longer. And this most recent data available will be used. And so we're grateful for the technical changes that this legislation, not just the funding, but that there's been so much work been done by members and staff to ensure that in some ways we can, of course, have transparency and greater inclusion in this. And just as a point of information, just sharing, I heard one of my colleagues speak about single parents, single mothers, but fortunately, this legislation also deals with married couples as well. This is not simply for single parents, single mothers. This is for young families. As a mother of 5, fathers need to change diapers too. And so I'm grateful that men are also included in this.
Not very well.
Oh, you have enough practice. You'll do it very well. Thank you very much. So thank you so much, and I yield back.
Thank the gentlelady. I think the gentleman from Texas would like to be recognized on the amendment.
Thank you, Mr. Chairman. I'd like to strike the last word.
Gentleman's recognized.
Mr. Chairman, this legislation reflects the compassion, thoughtfulness, and commitment to taxpayer stewardship that epitomizes Jackie Wolorski as a lawmaker and a leader of our great country. She was a pillar of our committee and the heart and soul of the Worker Family Support Subcommittee.
Good job.
Obviously a very dear friend, and we'll miss her sorely. She had, to me, a strong maternal presence that applied equal parts toughness and compassion as she worked on these programs. And I think this legislation is a big step towards ensuring that these compassion programs have both are meeting the needs of those it was intended to meet, but also are accountable to taxpayers. So I think this in many ways is a model for programs like this to ensure we're not just making ourselves feel better by just spending money, but actually meeting the real needs and achieving the desired outcomes. And with that, I yield back.
Are there other members who wish to be heard on the amendment? The gentleman from Kansas, Mr. Estes, is recognized.
Thank you, Mr. Chairman, and thank you to my friend and excuse me, thank you to my friend and colleague Congressman Winstrup for introducing this tribute to our friend Jackie. I want to echo my condolences to Jackie's family who are here with us today, husband Dean and mother Mert. Thank you for being here in the room where your wife and daughter spent so much of her time on behalf of others. I vividly remember hearing about Jackie's passing last month. Like many of us here, we were in our district traveling with staff, talking with constituents like Jackie was doing that day. You know, being out in the community was second nature to her. I mean, she lived a life of service, whether it was here as a member of Congress or as a missionary, where not surprisingly she worked with a lot of children through that process. I know there are constituents in her district and lives she touched across the world who mourn her loss. For us here today, we've not only lost a colleague, but a friend as well. Jackie was one of the first members of Congress who reached out to me early in my congressional journey, and I looked to her as a mentor through that process. You know, she was always a fierce fighter who worked for Hoosiers that she represented, and she was a joy to be around. I still laugh, you know, as I look at the picture every time I look up and see her smiling face. I mean, that's just typically Jackie. She worked hard, never backed down on her principles, and was always somebody you could count on to defend families and friends and children across Indiana as well as the country. I think it's a great honor for her life and legacy that I can think of no better way than to establish the Jackie Wolorski Center for Evidence-Based Case Management. Countless children and families have already benefited for her tenure in Congress, and with the Jackie Wolorski Center, many more will benefit from her legacy. And with that, I yield back, Mr. Chairman.
Thank the gentleman. Are there other members who wish to be heard on the amendment? Hearing none, the chair is prepared to ask the question to be raised. All those in favor of Dr. Winstrup's amendment signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it. We are prepared now to proceed to the next measure. If there are no amendments, the question is on the adoption of the amendment in the nature of a substitute as amended. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute as amended is agreed to. Now let me recognize the gentleman from California, Mr. Thompson, for the purpose of offering a motion.
Mr. Chairman, I move that the committee do now favorably report H.R. 8876 as amended to the House of Representatives.
Thank the gentleman. All those in favor signify by saying aye.
Aye.
Those opposed, no. In the opinion of the chair, the ayes have it. The motion is agreed to, and H.R. 8876 as amended is ordered favorably reported to the House of Representatives.
Mr. Chairman,
You can clap.
I would like to request. Mr. Chairman, I would like to request a recorded vote because I believe everyone on this committee would like to have their names recorded in association with this bill that we're passing today.
Are there any objections? Hearing none, the clerk will call the roll.
Mr. Doggett.
Aye.
Mr. Doggett votes aye. Mr. Thompson.
Aye.
Mr. Thompson votes aye. Mr. Larson.
Aye.
Mr. Larson votes aye. Mr. Blumenauer. Mr. Kind. Mr. Blumenauer votes aye. Mr. Kind. Mr. Pascrell.
Aye.
Mr. Pascrell votes aye. Mr. Davis.
Aye.
Mr. Davis votes aye. Ms. Sanchez. Ms. Sanchez.
Is she muted?
Sanchez votes aye.
Ms. Sanchez votes aye. Mr. Higgins. Mr. Higgins votes aye. Ms. Sewell. Ms. Sewell votes aye. Ms. Delbene. Ms. Delbene votes aye. Ms. Chu.
Aye.
Ms. Chu votes aye. Ms. Moore. Ms. Moore votes aye. Mr. Kildee. Mr. Kildee votes aye. Mr. Boyle. Mr. Boyle votes aye. Mr. Byer. Mr. Evans.
Aye.
Mr. Evans votes aye. Mr. Schneider.
Aye.
Mr. Schneider votes aye. Mr. Swazi.
Aye.
Mr. Swazi votes aye. Mr. Panetta. Mr. Panetta votes aye. Ms. Murphy.
Aye.
Ms. Murphy votes aye. Mr. Gomez. Mr. Horsford.
Aye.
Mr. Horsford votes aye. Ms. Plaskett.
Aye.
Ms. Plaskett votes aye. Mr. Brady.
Mr. Chairman, today we are all happy Hoosiers. I vote aye.
Mr. Brady votes aye. Mr. Buchanan.
Aye.
Mr. Buchanan votes aye. Mr. Smith of Nebraska. Mr. Smith of Nebraska votes aye. Mr. Kelly. Mr. Kelly votes aye. Mr. Smith of Missouri. Mr. Smith of Missouri votes aye. Mr. Rice. Mr. Rice votes aye. Mr. Schweikert. Mr. Schweikert votes yes. Mr. LaHood.
Aye.
Mr. LaHood votes aye. Dr. Wenstrup.
Yes.
Dr. Wenstrup votes yes. Mr. Arrington.
Yes.
Mr. Arrington votes yes. Dr. Ferguson. Dr. Ferguson. Mr. Estes. Mr. Estes votes yes. Mr. Smucker. Mr. Smucker votes aye. Mr. Hearn. Mr. Hearn votes aye. Mrs. Miller. Mrs. Miller votes aye. Dr. Murphy. Dr. Murphy votes yes. Mr. Kustoff. Mr. Kustoff votes aye. Mr. Kind. Mr. Kind votes aye. Mr. Byer. Mr. Byer. Mr. Byer votes aye.
Good answer, good answer.
Mr. Gomez.
Gomez, aye.
Mr. Gomez votes aye. Dr. Ferguson. Mr. Chairman.
Aye.
Chairman votes aye.
Clerk will tally the roll.
Mr. Chairman, I have 41 ayes, one member not voting.
There being 41 ayes and one member not voting, the motion is agreed to, and H.R. 8876 as amended is ordered favorably reported to the House of Representatives. Without objection, staff are authorized to make technical and conforming changes to the print, and members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business is the committee print 1117-1, Improvements to Medicare Inpatient and Outpatient Mental Health Services. This bipartisan committee print makes 2 important changes to the Medicare program, improving the inpatient psychiatric facility payment system and adding intensive outpatient program coverage for individuals with mental health and substance use disorders as treatment is needed. The committee print includes the provisions of H.R. 8879 and H.R. 8878, and I want to thank Representatives Evans, Representative Arrington, Representative Chu, Representative Pascrell, and Adrian Smith for their contributions to this measure. These are important considerations and will improve access to care and treatment for Medicare beneficiaries. We worked together on a bipartisan basis through the Support Act. The last time we added a mental health service to Medicare, opioid treatment programs, and I'm quite pleased with what we are doing again today as it relates to outpatient services. Now let me recognize Mr. Brady for the purposes of an opening statement.
Thank you, Mr. Chairman. This print includes two bills, the Inpatient Psychiatric Facility Improvement Act and H.R. 8878, which deals with intensive outpatient treatment. I, too, would like to commend Representatives Adrian Smith and Arrington, as well as our friends, Representative Pascrell, Chu, and Evans, for their excellent bipartisan work. Both these bills are all about improving the care Medicare beneficiaries receive for mental health and substance use disorder, and making sure they're receiving care that's based around them and their personal needs. These are good policies that address vital needs, and I look forward to continuing to work on them in a bipartisan manner.
The committee will now proceed to consideration of the committee print 11-7-1 as amended. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. Let me now turn to the very capable Staff Director, Amy Hall, of the Subcommittee on Health, to provide the technical description of the amendment in the nature of a substitute with an emphasis on the changes made since notice. I ask that members hold their questions until after the presentation. Ms. Hall.
Good morning, Chairman Neal and Ranking Member Brady. Committee Print 117-1, Improvements to Medicare Inpatient and Outpatient Mental Health Services. Section 1 amends Section 1886S of the Social Security Act to require the Secretary of Health and Human Services make improvements to the Medicare Inpatient Psychiatric Facility Payment System in a way that would better incentivize care and treatment of Medicare patients in these settings. Section 2 amends Section 1861FF to add a new definition for intensive outpatient services to fill a gap in the continuum of care for Medicare beneficiaries. This would ensure that these services, which provide a level of care between inpatient and partial hospitalization services and physician office visits, are available to Medicare beneficiaries beginning in 2024. The amendment in the nature of a substitute makes the following change. On page 1, line 5, strike information. That concludes my walkthrough, and I'm happy to answer any questions.
Thank you, Ms. Hall. Now we will proceed to questions about the amendment in the nature of a substitute. The gentleman from Texas, Mr. Doggett, is recognized.
Ms. Hall, I gather you've been working on this matter for some time.
I've been with the committee since 2014.
No, I'm not talking about your length. I'm talking about this particular legislation that you just described. You've been working on it for a good bit of time.
The staff and Chairman Neal have been working on Medicare mental health policies for quite some time. As you know, we had a hearing, I believe, back in May, where we discussed, February, excuse me, where we discussed a number of these policies, yes.
And sometimes a discussion draft approach is used. Has a draft of this first measure or any of the other drafts, any of the other measures in this package been circulated outside the committee to stakeholders?
The draft was circulated to the Centers for Medicare and Medicaid Services for technical assistance, which we worked with Ranking Member Brady's staff over a number of weeks to improve the language.
For example, any of the groups that came and testified before us in February, were any parts of this package circulated to them?
We did share, we have worked with a number of the groups that, including some who testified, to provide feedback. And in fact, to better understand, for example, the Legal Action Center came to us with a number of questions regarding Medicare coverage, and so we've been working with them for a number of months to better understand their concerns with the way Medicare coverage works.
Good to hear that.
And I think there were some misunderstandings, and anyway, so yes.
Yeah, that's helpful, and I believe the first time you advised all of the health care staff of the members of this committee on the Democratic side that this markup would be coming and what kind of bills would be before us was last Monday.
I believe that over the course of the past few months, we've had a number of conversations in both the member caucus as well as with the health LAs discussing the fact that we were working on a bipartisan basis toward an agreement on these policies.
Sure,
We have described.
but I'm just talking about the bills that we have up today. You gave a general description of them for the first time last Monday.
I actually think that in August and also in July, we talked about the contours of the policies, including looking into the inpatient psych payment system.
Can we agree the first time that we've seen the text of the bills we have today was on Monday?
The markup and the committee prints were noticed on Monday, yes.
And we actually got the legislative text so that we could see what the bills provided just before 10 o'clock in the evening, the day before yesterday, before our hearings yesterday.
Yes, the markup was noticed around 10 p.m. on Monday night.
Okay. And Ranking Member Brady has expressed concern about cost and how we are going to pay for cost. I don't believe we have a score yet. What is the cost of this measure and the other measures we have before us?
So as is committee practice, the legislation does not have to have a score in order to be considered before the committee. We do not know yet from the Congressional Budget Office the exact score on these provisions as contained in the committee prints.
Well,
we anticipate, I think the chairman has said or is going to say, we anticipate working with CBO to get information on the cost of the bills prior to moving to the floor.
Well, of course, I understand the rules don't require it, but do we have even a guesstimate of what this package of multiple bills that we first got text on the night before last will cost?
So let's see. The inpatient psychiatric provision is budget neutral. That should not have a cost. Mr. Thompson's legislation Relating to marriage and family therapist coverage, in the past, when CBO has looked at it, it has been around $1 billion. Obviously, you know.
1 billion? Okay.
The other provisions relating to private insurance and transparency, I don't anticipate they're going to have a cost, but of course, I am not the Congressional Budget Office, so we will have to wait to see what they say.
Okay, thank you. And you'll be available to answer questions on each of the different packages that you have here.
Yep.
Thank you.
Let me just take a moment. Ms. Hall and I have talked extensively about this over the course of many months, and as recently as in the last few weeks, Mr. Thompson and I have talked about this extensively, and he has hosted gatherings to discuss precisely what's in front of us today. So the mental health issue has lingered with us for decades, and I think the fact that we're addressing it now is a very important consideration, and I think that we have adhered very carefully to the argument as to whether or not we need a score now or subsequently. I think Mr. Thompson would confirm what I've just said. I think if I recognize him for a moment.
Absolutely. This has been an ongoing conversation between not only the chairman and myself and staff, but members of the committee. And as the chairman points out, the mental health issue, mental health crisis has been with us forever. And I would also add that although important, the steps that we are taking today are pretty minor in comparison to what we need. This is a good faith effort by the committee to address this issue. The bills before us today, I think most of them, if not all of them, are bipartisan, and there's not a member on this dais who doesn't have the mental health crisis in their district.
I certainly concur with all of that, that there's much more that needs to be done, that we've discussed it widely. I think that in terms of member input, it's helpful to get these drafts of legislation in a timely fashion, because if you don't have the draft in a timely fashion, it's impossible to craft amendments that might help improve or to see that we address as much of this problem as we possibly can.
Thank you. Are there any other questions in the nature of the amendment in the nature of a substitute for the staff director? Hearing none, we now proceed to striking the last word. Are there members who wish to be recognized to strike the last word? The gentleman from New Jersey, Mr. Pasquale, is recognized to strike the last word.
I move to strike the last word.
Gentleman is recognized.
I'd like to thank Congresswoman Judy Chu, Congressman Adrian Smith for working with me to expand Medicare mental health coverage. Providing complete health care demands coverage for physical health and mental health. Around 1 in every 4, a full quarter of Medicare beneficiaries have a mental health issue, Mr. Chairman. We need to recognize it. Yet, these Americans often fall through a gap in the care as it presently exists. Medicare only covers the most and least restrictive settings for mental health and substance use disorder. That leaves out a lot of Americans. Our watershed legislation will fix that gap by finally creating a new benefit category for intensive outpatient service. This change is long overdue. The new policy will help the health coverage and mental well-being of millions of Americans. The committee print under consideration will make a huge positive difference in the lives of our seniors. I urge my colleagues' support. I thank you, and I yield back.
Thank the gentleman. The gentleman from Texas is recognized to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word.
Gentleman is recognized.
Mr. Chairman, Ranking Member Brady, thank you for the opportunity to be a part of this important reform. I want to also recognize the hard work of Representative Dwight Evans and express my gratitude for his partnership in this effort. The bill is that we put forward in this broader package is the Inpatient Psychiatric Facility Improvement Act. The inpatient psychiatric facilities, or IPFs, are acute care facilities for the most severe mental health disorders and patients who require the most serious and intensive treatments. These facilities are paid on a per diem basis, but the payment model that was devised some 20 years ago has not received any official audit, so we don't have any way of determining the cost effectiveness of this model. No visibility into the types of diagnoses and services rendered, or patient outcomes and cost of care. So there are outside groups like nonpartisan MedPAC, but there have been others who've looked at it and said the IPFs have been found to have inadequacies in post-discharge services, overutilization, cost of care, and I think most importantly, patient outcomes. So this is not an issue just for the sake of stewarding taxpayer dollars, but making sure we meet the needs and achieve the desired outcomes. And this bill is very straightforward, colleagues. It just requires the Secretary of Health and Human Services to audit the IPF payment model, collect data regarding the cost and utilization of IPF care, create an assessment tool that will look at diagnoses given, services rendered, and patient outcomes. I believe that this legislation will allow us as legislators to have a better picture of the services and that meet the reality of care in 2022, but will guide us in the necessary reforms to improve patient outcome and prevent overutilization and unnecessary spending. And so I encourage my colleagues to support this bill, and I thank you for, again, the opportunity to participate. I yield back.
Thank the gentleman. Let me recognize the gentlelady from California, Ms. Chu, to strike the last word.
Mr. Chair, I move to strike the last word.
Gentlelady's recognized.
As one of two psychologists in Congress, I want to express my deep appreciation to the chair and to this committee for the focus on the mental health needs of the American public and Medicare beneficiaries in particular. We know that mental illness and addiction do not suddenly stop at age 65, so neither should our health policies. The package of bipartisan bills before us today are a significant step forward in not just addressing the mental health crisis in America, but also making meaningful changes to our health systems to better support patients who are struggling. This committee print, in particular, contains important legislation that I'm proud to have worked on alongside Representatives Bill Pascrell and Adrian Smith, which would create a new Medicare benefit category for intensive outpatient services. These are services designed to treat individuals with mental health or substance use disorders who do not require the more intensive inpatient services such as hospitalization, 24/7 supervision, or medical detoxification. However, these are the types of patients who do require more treatment and care than could be provided in a typical outpatient visit. These additional services could include medication management, psychoeducation, or individual or group therapy, and are critical steps towards recovery for so many patients. But currently, the Medicare program does not cover intensive outpatient services as a benefit category. Instead, these services are covered with significant restrictions, such as requiring that patients be inpatient eligible. This has the unintended consequence of excluding many Medicare patients from the type of mental health services that are most appropriate for their condition and level of care. This is one of the many glaring gaps in the Medicare program that prevents mental health coverage from being at parity with physical health, something that Representative Pascrell and I have been working together to address. Our bill takes a step in this direction by closing this gap in Medicare benefits to ensure that no one falls through the cracks just because they require an intermediate level of care. It would allow outpatient hospitals, community mental health centers, rural health centers, and federally qualified health centers to deliver these services, meaning that patients can access care in the facilities that best meet their needs. One additional proposal that I've been working on with my Republican colleague, Representative Adrian Smith, would define peer support specialists in the Medicare program. And while I'm disappointed that it was not included in the packages before us today, I look forward to continuing to work with this committee to ensure that beneficiaries have access to mental health and substance use support staff at every level, from physicians to social workers to those with lived experiences who can help guide patients towards recovery. I would once again like to thank the chair for his commitment to prioritizing mental health as part of this committee's work, and I urge my colleagues to support the committee print before us today. I yield back.
Thank the gentlelady. Let me recognize the gentleman from Nebraska, Mr. Smith.
Thank you,
Strike the
Mr.
last
Chairman.
word.
Thank you to you and our ranking member for bringing this bill up for consideration. Access to adequate mental health care resources has been a challenge for rural areas like my district for some time. The recent COVID pandemic highlighted just how important protecting our mental health is for all of us. The bills we are marking up today represent an important step for this committee, and they show just how much can be accomplished on a bipartisan basis. I'm especially pleased today to see that one of today's bills includes legislation I recently introduced, which would create the new Medicare coverage opportunity for intensive outpatient programs. Appreciate Ms. Chu's mention of that and her work on this as well. Advancements in medical knowledge and technology have revolutionized the way mental health care is delivered, and in many areas, care has transitioned away from psychiatric hospitals and toward community-based outpatient care. Unfortunately, Medicare coverage has not always kept pace with these changes. This bipartisan bill brings new flexibilities in coverage, specifically targeting those who might need more therapy than traditional outpatient services, but not so extensive to need inpatient admission or even partial hospitalization. Intensive outpatient programs fill an important gap in the spectrum of Medicare's mental health care options. This will help us channel our existing resources like rural health clinics, federally qualified health centers, and community-based mental health providers so they can be more effectively utilized by those seeking mental health care. Again, I'm happy to see this bill included in the markup today and hope to see its eventual enactment in a larger bipartisan mental health care package before the end of the year. Also, I would like to mention, as Ms. Chu did, another mental health bill that we have been working on, the PEERS Act, allowing for peer support specialists to participate in behavioral health integration services covered through Medicare. This is a low-cost, common-sense bill which would increase access to effective resources already available in communities across the country. Unfortunately, we were not able to get this bill included in today's markup, but I hope with a little more time to incorporate feedback from CMS, this bill can be included at a later stage in the legislative process. Thank you again for putting together this markup of critical bipartisan mental health legislation. Let's keep working together and make sure this gets across the finish line.
Thank the gentleman for his comments. The gentleman from Pennsylvania, Mr. Evans, is recognized to strike the last word.
Mr. Chairman, I would like to strike the last word.
The gentleman's recognized.
I strongly support this legislation, which includes my Inpatient Psychiatry Facility Improvement Act. I appreciate Representative Arlington's introduction to this bill and his relationship of working together. I thank him. This bill will improve access to inpatient psychological care and create a system that better cares for individuals who seek the care for these facilities. It will also provide a needed oversight to ensure that these facilities that care for the most vulnerable are lived up to the responsibility they have to their patients. Mr. Chairman, I thank you for your leadership on this and your commitment with this package. I look forward to moving this bill and our larger mental health package forward, and thank you for your leadership for bringing everybody together on this committee to push this package. Thank you. I yield back to you.
Thank the gentleman. Let me recognize the gentleman from Georgia, Dr. Ferguson, to strike the last word.
Mr. Chairman, move to strike the last word.
Gentleman's recognized.
Thank you, Mr. Chairman. Before I make a comment on this mental health package, want to express my support for the Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act. Although my vote was not recorded, it is a significant piece of legislation.
Yeah, so ordered.
Thank you so much for that, and we look forward to the continuing discussion on this bill. I yield back.
Thank the gentleman. Let me recognize the gentleman from Oregon, Mr. Blumenauer to strike the last word.
Thank you, Mr. Chairman. I'm encouraged with the spirit with which we're moving forward, being able to integrate a variety of areas for reform. The reference that has been made about additional flexibility, broadening our ability to, for example, to deal with outpatient care. We're overwhelmed in community after community with the stresses that we've seen. Nobody on this committee is immune in our community or people that we know. The COVID-19 crisis has played a significant role in exacerbating these issues. And it's clear that we've been facing a crisis long before the pandemic. I think this crafting the Support Act is an important step forward, but it's just, I think, transition. We need to continue moving forward. There are a number of areas that deeply concern me. I've spent a long time working on end-of-life care, which has profound impact in terms of mental health that individuals have to be able to cope with some of the most trying circumstances that they and their families would vet. I think there's a need for us to continue moving in that area. Oregon is involved in an experiment with therapeutic psilocybin that is indicating that there's some real potential to be able to deal with addiction, to deal with some of the end-of-life care, the ways that have less impact than some other traditional therapies that I think have a lot to commend them. So I appreciate our colleagues being interested in the elements here to try and broaden flexibility now and commit it to the future. But I think that this is an area that the committee is going to have to spend a lot of time going forward. And even though it looks like we're expending some money, I am convinced that the savings doing this right is going to more than pay for it. Someday we will get the CBO to understand present value accounting, which would make a lot of this easier. But I hope that we'll continue down this path, and I appreciate the bipartisan spirit that's been invested and the creativity that people have advanced.
Thank the gentleman. Let me recognize the gentleman from Texas, Mr. Doggett, to strike the last word.
Thank you very much, Mr. Chairman. This bill that is sponsored by Ms. Chu is likely the most substantive proposal and the most meaningful of all those that we are considering today. It closes a coverage gap for beneficiaries who do not require inpatient or partial hospitalization treatment, but who may well be on the brink of a crisis demanding more intensive outpatient mental health services. By ensuring that Medicare covers treatment for patients requiring 9 to 20 hours of care a week, this legislation improves continuity of care and will help prevent full-blown health crises. However, like the other legislation that we are considering today, adequate notice and time for review would have provided an opportunity to strengthen its provisions. Indeed, Ms. Chu has already indicated that the bill as presented and drafted by staff does not include some of her other priorities. I have complained in prior Congresses about short notice from Republicans, and it's only consistent to express the same concern here. On major legislative items like this, not getting legislative text until almost 10 on Monday night and not even having the sponsors of these various measures and how they would be packaged identified until we were in hearing yesterday morning is not sufficient. While the Legal Action Center, for example, that we discussed earlier, recommended the provisions that form this bill, and they did so during our hearing here in February, they made a number of additional points in that hearing as well. And they rushed over a comment letter last night, since I assumed they only got the legislative text when we did, concerning other issues that need to be improved in this bill. I agree with them that the legislation should clarify the new intensive outpatient therapy benefit will include substance abuse disorder. That was one of the major issues we considered in our prior hearing, and that all appropriate care settings for such treatment should be covered by Medicare. That may well affect the cost estimate, though since we don't have the cost estimate yet, it is a consideration as we move forward to the floor. They've also called for re-examination of the 190-day lifetime limit on inpatient treatment. an issue that I believe warrants further consideration. Finally, the Legal Action Center made a number of points in February and again in their submission for today, last evening, concerning improved data collection, issue dealt with by Mr. Evans, modernizing technology, and ensuring coverage aligns with current medical standards of care and patients do not face inappropriate access barriers. So while there's merit to both of these bills, more could have been achieved with greater input, involvement, and notice. I yield back.
Let me recognize the gentleman from Illinois, Mr. Davis, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last.
Gentleman is recognized.
Mr. Chairman, the World Health Organization reported that an estimated 450 million people in the world suffer from mental or behavior disorders. These mental disorders are especially prevalent in prison populations. America is 1/5 of the world population, but we incarcerate more people than any other country in the world. Therefore, it's been estimated that 70% of the incarcerated are nonviolent offenders. The skyrocket incarceration rate has become, for many with mental issues, a dumping ground for jails and prisons. Regardless of the appropriate assessment and due process, the justice system for those individuals is not fair, especially disproportionately for Black and Latino populations and other minority groups. People with substance abuse disorders are, at least in part, due to mental disorder, have committed minor offenses and are usually sent to jail or prison rather than treating them for their mental disorder. These disorders oftentimes go unnoticed, undiagnosed, and untreated. In my district, the Cook County Jail has one of the largest populations of mental illness among people in America. Public institutions of incarceration are usually bad for people who need help for treatment for their disorders due to overcrowded settings, intense violence, lack of privacy, lack of meaningful activity, insecurity about future prospects like work, relationships, family support, and other matters. So I support my colleagues, Representative Judy Chu, Bill Pastrell, Adrian Smith, Dwight Evans, and all who are promoting need for additional treatment for individuals with mental disorders. And I yield back.
Thank the gentleman. We will now proceed to the amendment stage, and I believe that there has been no request for amendments to be offered to the legislation. So all of those in favor of this legislation could signify by saying aye. Aye. Those opposed, no.
Aye.
In the opinion of the chair, the ayes have, and the amendment in the nature of a substitute is agreed to. Now let me recognize Mr. Thompson for the purpose of offering a motion.
Mr. Chairman, I move that the committee agree to Committee Print 117-1 as amended.
The question is on agreeing to Committee Print 117-1 as amended. Members are reminded to unmute themselves for the purpose of a voice vote. All those in favor signify by saying aye. Aye.
Aye.
I think there's an echo. Those opposed by saying no. In the opinion of the chair, the ayes have it. The motion passes, and Committee Print 117 as -1 is amended is agreed to. Our next order of business is Committee Print 117-2, improvements to the Medicare program related to physician services and education. The bipartisan legislation makes a number of important changes to Medicare. First, it expands access to treatment by including marriage and family therapists and mental health counselor services as provided under Medicare. Second, it requires the Secretary to conduct 2 important outreach campaigns related to opiate treatment programs and behavioral health integration codes. And I should note that I am quite pleased with the progress we have made with opiate treatment here in the committee. I know that Medicare beneficiaries are not accessing these services to the extent that they should, which was intended by our legislation that previously passed. This legislation ensures that hospitals and other facility-based providers can offer mental health and substance use support for physicians and other providers that are not direct employees. Finally, recognizing that there are a number of contingency management programs that incentivize individuals with substance abuse disorders to continue with their full course of treatment, the legislation directs the Inspector General to examine how best to clarify that in federal regulations. Let me thank our Ways and Means members, Mr. Thompson, Mr. Jason Smith, Mr. Schneider, Mr. Ferguson, Mr. Higgins, Mr. Kelly, Mr. Byer, Dr. Murphy, Mr. Panetta, and Mr. Estes for their important contributions to the committee print. Earlier this year, we spent a lot of time during 2 full committee hearings discussing the ways we can support provider workforce managing burnout from COVID-19 pandemic, as well as expand access to new providers. The provisions in this committee print address some of these challenging issues that are key to ensuring access to mental health services for Medicare beneficiaries and supporting our workforce. Now, let me recognize Mr. Brady for the purpose of an opening statement.
Thank you, Mr. Chairman. This print includes 5 bills, 4 of which are led by bipartisan groups of members from the committee. So I'd like to commend as well Representatives Kelly, Jason Smith, Estes, and Murphy, as well as Representatives Thompson, Higgins, Byers, Schneider, and Panetta for the great work on these policies. Included in the print are important policies to reduce physician burnout, ensure government regulations aren't unnecessarily stepping in the way of beneficiaries receiving evidence-based treatment options for substance use disorder, and improve outreach to providers and patients, make sure we're getting the most out of the services already available. I'm glad to advance the ball on these policies today. Look forward to working with the majority on the offsets and to make a bigger point on the package. Sad truth is we really don't have a mental health system in America. And I think, try as we have, and I think the COVID and the pandemic pulled the curtain back on that, just as it revealed that we don't do well in isolation. And the tension now in mental health from the very youngest to the very senior is greater than ever. So as I looked at this package, Mr. Chairman, it seemed to me this was a great opportunity to find common ground on the policies members have been working on, advance them as we continue to improve upon them, and then because other committees have acted in their jurisdiction on mental health, I think it's really important for those of us who hope that we can act before the end of this session. This is an important step today to make sure we're in a position to help shape these mental health policies in a positive way, leave our imprint as a committee and on behalf of our members on this important issue. So with that, I think this package is an important step for us in this regard. And again, look forward to working with you on it.
Thank you. And for seniors, I remind all that we actually amended an entitlement program successfully here as it related to opiate treatment. It was a substantial achievement. But I also want to acknowledge the point that Mr. Davis made, and that is that our jails and our homeless shelters are full of people now with mental health issues. And trying to address that is going to be a staggering challenge, again, for all of us here in Washington, working with state governments as well. But it's a huge problem, and we all know of it. So without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for the purposes of amendment. Let me now turn to Amy Hall, again, our very capable staff director for the Subcommittee on Health, to provide the technical description of the amendment in the nature of a substitute, with an emphasis on changes made since notice. I ask that members hold their questions until after Ms. Hall's presentation.
Committee Print 117-2, Improvements to the Medicare Program related to Physician Services and Education. Section 1 amends Section 1861 S2 by adding a new double L that provides for Medicare coverage of marriage and family therapist services and mental health counselor services under Medicare within their scope of practice under state law beginning in 2024. Section 2 requires the Secretary of Health and Human Services to conduct an outreach campaign related to behavioral health integration codes and requires a secretarial report on the utilization of such codes. Section 3 requires the Secretary to conduct outreach to providers and beneficiaries related to opioid treatment program benefits under the Medicare program, as well as a secretarial study on that matter. Section 4 amends Section 1877E and 1128B of the Social Security Act to ensure that physician, mental, or behavioral health wellness programs, such as counseling, suicide prevention, and substance use disorder treatment, are permissible under the Stark and anti-kickback laws so that these programs can be offered in their community. Section 5 requires the Inspector General under Section 1128D to conduct a review on whether to establish a safe harbor for evidence-based contingency management incentives and the parameters for such a safe harbor within 1 year of enactment. The amendment in the nature of a substitute makes the following change. On page 8, line 15, insert beneficiaries after the word those. That concludes my walkthrough, and I am happy to answer any questions.
Thank you, Ms. Hall. Let me proceed to the next phase, and that is, are there any questions about the amendment in the nature of a substitute? The gentleman from Texas, Mr. Doggett, is recognized.
Thank you. So, Ms. Hall, is the provision that deals with marriage and family counselors, that's the one that you believe cost in the range of $1 billion?
So in the past, when we have been having bipartisan conversations about Mr. Thompson's legislation, that's around the range. Please don't quote me on that, but somewhere around there. And of course, we've got an additional year of the budget window with more beneficiaries, but on the other hand, we have more people in MA, which might affect, we have a new IOP benefit, which is the subject of this markup. So
And that, of course, is
somewhere in there.
We'll eventually hear from CBO on that. But
Yeah.
and on the bill that we just approved of Ms. Chu, I don't believe I got a number on that. What is the estimate of how much it cost?
We do not have any, I don't have any preliminary information from CBO. I don't know if anybody else does. The first provision relating to IPF facilities, as I mentioned, that provision is budget neutral, so therefore that would not be expected to have a cost.
But you would expect some cost with the Chu bill, would you
With
not?
the IOP provision, yes.
And there's no estimate from CMS or anyone else as to what that cost?
No, sir.
Could it be more than the Thompson bill?
I mean, I don't have any way to gauge that. The incidence of this isn't how should I say it? It's not like 75% of Medicare beneficiaries, for example, a diabetes screen or a congestive heart failure test, right? That's something that is more prevalent in the population than, say, the need for intensive outpatient services, right? So there's a smaller universe of people who are going to need those, but we just don't have a sense, right?
And on Section 4 of this bill, has the administration declined to inform providers the information that you're talking about here? Is this legislation necessary because the Biden administration just simply will not do this, which they have the power to do already?
I just want to be clear. Section 4, you're talking about physician wellness programs?
I'm talking about the advising the physicians portion of this bill.
In terms of the education campaign?
Yeah, the education campaign.
Okay. So there are two education campaigns. The administration has, in fact, done some work through a MedLearn article related to behavioral health integration codes, but the take-up remains low. So the notion here is that we are asking the administration, and I believe we anticipate providing some resources at some point for the administration to actually do some more targeted intervention and education on both these codes and the opioid use disorder treatment, which this committee passed, as you recall, a couple of years ago.
The administration has not yet been asked to do these things, but through this bill, you hope to provide them the resources to do them once they're asked.
Yes, however, the Inspector General did recommend that the administration take steps on targeted outreach related to opioid use disorder programs. They have not, to my knowledge, done that yet.
And will this be a matter of emailing providers or sending out brochures, or what kind of education campaign do you anticipate?
So in the past, when we have done, when Congress has legislated specific outreach initiatives like this, they usually do a couple of things. They will convene providers, certain provider types that are frequently billing these services to inform them, here's how you can bill these services, here's what they're used for. Sometimes they will send targeted mailings. I think it depends. We've given the administration flexibility to design this in the way that they think best reaches.
And when you refer to resources, again, what will be the cost of the resources that you propose to give them?
Give me 1 second, let me look. The administration has a fairly robust budget for provider education, generally speaking.
Yes, they could do that already without a bill.
Without a bill, but the notion is they haven't. And here we sit knowing, for example, that 50% of adults and children are not accessing services they need.
So what new resources are you proposing in this bill to give them?
There are, to my knowledge, no new resources in this specific committee print. Like this, there's not like a funding stream.
I thought you told me earlier that you thought
I think the
additional
notion
resources would be needed.
I'm sorry, let me be clear. I think the notion is the administration has within their Medicare budget, both for the MACs, the Medicare Administrative Contractors, and generally speaking, for Medicare at large, has resources in order to fund such a program. We will work with Ranking Member Brady and obviously the other committees as this goes through the process. Should the administration decide they need supplemental resources, that can be subject of the conversation.
So I think we might treat this as a measure on the House floor as to what is known as a motion to instruct. Broad category. Are there any other questions about the amendment in the nature of a substitute? Now we will proceed to striking the last word. Is there any member who wishes to strike the last word? The gentleman from California, Mr. Thompson, is recognized to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word.
The gentleman's recognized.
Thank you for having this hearing today. As we all know, we have a mental health crisis across our country. It's in all of our districts. It affects veterans, teenagers, the homeless, the elderly, the incarcerated, and those struggling with addiction. And even our own healthcare workforce is hit hard by this. It's a problem everywhere. I'm grateful that we're having this hearing today and dealing with these pieces of legislation. I'm particularly pleased that the committee today considers the Mental Health Access Improvement Act, bipartisan legislation of mine, establishing Medicare coverage of mental health services provided by licensed mental health counselors and marriage and family therapists. There is ample evidence that seniors suffer from a wide range of mental illnesses, from depression to bipolar disorder to anxiety to cognitive impairment. Fortunately, these medical health challenges can be effectively diagnosed and treated if appropriate care is sought. But today, due in part to provider shortages and an ongoing ever-growing medical population, many seniors do not have access to the care they need, and many do not even seek care in the first place. That's why this bill is so important. It adds thousands of qualified mental health professionals to the Medicare program, a substantial increase in the pool of providers available to our senior populations, while ensuring that seniors can access these services in rural health clinics and qualified health centers. I'm proud to have led this bill for several straight Congresses with my Republican colleague, Mr. Kotko, and I look forward to working with my colleagues to get this and other vital mental health legislation signed into law. However, I want to reiterate a point I've made in our previous mental health hearings, and I've made it to many of you on a person-to-person basis. While I'm proud to support these bills, the fact of the matter is everything that we've done in regard to mental health and everything that we're doing now is treating symptoms. And we don't have enough time, we don't have enough money, we don't have enough resources to continue to do that. We have to get ahead of the curve. We need to step up and provide the funding necessary to do the brain research that's necessary to get to the bottom of these problems so we can start, so we don't have to always use the Band-Aid approach. That's not going to work. There's some good ideas out there. There's some fantastic work being done. Some of you know I invited you invited everybody to a meal the other night to hear from a constituent of mine who's started the One Mind Foundation, and we've heard of the good work that they're doing, and it's just incredible how much positive work is coming out of this research. And we need to step up and do all we can to ensure that they have the funding sources necessary to not only continue to do the research they're doing, but to expand that. We have got to get to the bottom of this problem, and that is a challenge that we all need to meet, and one that will help all of our districts and will help our country. So thank you, Mr. Chairman. Thanks to all my colleagues for recognizing the importance of doing the good mental health work that we're doing, and I hope we can all make a commitment to double down and really make a difference in this field. Thank you. I yield back.
Word of thanks too, Ms. Thompson. I have met your constituent in California, visited with them on site, and also proceeded a number of times. That individual has visited Washington. It's a powerful story, and I believe we have a request from CBO for a score on the legislation right now that they are sponsoring. So we're pleased with the direction that is taking. The gentleman from Georgia, Dr. Ferguson, is recognized to strike the last word.
Move to strike the last word. Okay. Mr. Chairman, I want to first say that I'm extremely grateful that we're doing this. I made mention of that earlier, but what we've seen happen across our country with the mental health crisis, it's devastating, and it's devastating across every socioeconomic group, across every age. There's not a demographic or a community that hasn't been touched by this, and I think in many regards, particularly with our younger population, both our teenagers and our youth, they have really been challenged in so many ways through the pandemic, and they tend to be more fragile at this point than maybe their predecessors have been. And so I'm thankful that we're focused on this. I'm grateful for the work that the Congress has done in a very bipartisan basis. But one of the things that I want to particularly talk about is HR 8910, Behavioral Health Integration Awareness Act, and been very proud to work with Jason Smith and Brad Snyder to introduce this bill. And it really aims to address a problem that's at the heart of this country's mental health crisis. And Behavioral Health Integration Awareness Act would require the Secretary to reach out and effectively communicate with physicians and other healthcare professionals who accept Medicare in order to inform and raise awareness of behavioral health integration services that are available to the patients. And the goal of this bill is to increase the uptake. We've done a lot of work around the country on this, but we still need patients and physicians using the services. And this is going to increase, and I think if we're wise, we will look further down the road in additional legislation, because we are going to need not only an uptake of services that we have now, but we're going to need an increase in the number of providers. And I know that we have talked about that in this committee, and there have been some steps taken in other legislation to increase this. But not only do we need increased utilization, but we're going to need a significant number of providers going forward. And we're going to need to understand that this is going to have a lasting impact on healthcare. But anything that we can do for early intervention, early uptake, early treatment, I think is going to be important. So we think that this bill is an important tool in addressing the mental health crisis. And again, I encourage everyone to support this. And with that, Mr. Chairman, we'll yield back.
Thank the gentleman. Let me recognize the gentleman from New York, Mr. Higgins, to strike the last word.
Thank you, Mr. Chairman. Opioid use disorder affects a rapidly growing number of older Americans. Between 1999 and 2019, the rate of opioid overdose deaths rose tenfold in adults ages 55 and older. Although Medicare now covers medication-assisted treatment for seniors with opioid use disorder, far too few older Americans with opioid use disorder actually receive that treatment. Medicated-assisted treatment is one of the most powerful tools we have to combat opioid use disorder, but a lack of awareness by both patients and providers that treatment is covered under Medicare keeps many seniors from accessing that assistance. The education initiative required by the Medicare opioid use awareness and access to opioid use disorder treatment options for seniors. I'm proud to join in leading this legislation with Mr. Kelly that will help get more Medicare beneficiaries connected to treatment and prevent overdose deaths. I yield back.
Thank the gentleman. Let me recognize the gentlelady from West Virginia, Ms. Miller, to strike the last word.
I move to strike the last word.
Gentlelady is recognized.
Thank you, Chairman Neal and Ranking Member Brady. I rise today in support of this committee print number 2. There are so many great bills that are included in this committee print. As many of the people on this committee know, my district was one of the hardest hit by the opioid epidemic. As communities across the United States are working to recover from this devastating impacts of illicit drugs, it is important that physicians have the tools at their disposal to help those who need it most. This legislation helps to ensure Medicare beneficiaries have access to care for both opioid and stimulant use. It also helps ensure that physicians are supported and will help to reduce burnout, which is so important as we emerge from the pandemic. I urge my colleagues to support this committee print, and I yield back the remainder of my time to Dr. Murphy.
Thank you, Ms. Miller. Mr. Chairman, I move to strike the last word. I want to come out in support of the Physician Wellness Program Act. This would allow healthcare entities to provide mental health programs to providers, whether they're directly employed by the facility or not. One thing that we're experiencing so much in this country now is a term called locum tenens physicians. These are physicians who are not directly employed by a practice, not directly employed by a hospital, and they're, if it is to say they're migrant to that hospital itself, but they provide such a large component of the workforce that we're going on today. I get a text every morning from our hospital system, which covers a 29-county area, and about 90% of the time now, we are in what we call a code red. We don't have enough adequate workforce available to take care of the patients. And this is what we're seeing now time and time again. It's not an isolated incident, and this is happening across the country. We have an aging, burned-out physician population in this country. We worry constantly about Medicare cuts, massive government overregulation, the constant threat of being sued, and routinely, our physicians are working 12 to 14-hour days. So now, seemingly after COVID, that it's been reported that 1 in 5 physicians plan on retiring in the next 3 years. 1 in 5, and this is in a field that is already deplete with physicians. We're in a field that we often ask our patients, how are you doing? And rarely, because physicians, sometimes this is seen as a sign of weakness after years of study, after years of training. It's seen sometimes as a sign of weakness that we actually ask that question ourselves. So I think this is a tremendous effort to try to deal with physician burnout and to try to deal with physician wellness. It doesn't spend a dime and creates a minor exception to an existing law that will indeed have a profound effect amongst our workforce. I urge my colleagues to vote for this. Thank you, Mr. Chairman. I yield back.
Thank the gentleman. Let me recognize the gentleman from Virginia, Mr. Byard, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word.
The gentleman's recognized.
Thank you, Mr. Chairman. Mr. Chairman, my bill with Dr. Ruiz, Dr. Murphy, and Dr. Bouchon, the Physician Wellness Program Act, is included in this committee print, which takes steps not only to address mental health more seriously among healthcare professionals, but also help with burnout. I'm pleased that 3 physicians allowed me to partner with them. Just yesterday, the American Medical Association announced that physician burnout is at an all-time high. A recent study in the Mayo Clinic proceedings found that the burnout among physicians was 62.8% in 2021, and that 1 in 5 physicians might leave their current practice within the next 2 years. Previous studies have found that beyond impacting the doctors themselves, burnout among our health professions is associated with decreases in the quality of care, in patient safety, and in patient satisfaction. The mental well-being of our healthcare workforce was already a concern before the pandemic, but it's only been exacerbated since then. Congress can do more to support the mental well-being of society, including our health professionals. The Physician Wellness Program would boost wellness and access to mental health resources by amending the Stark Law and the anti-kickback statute to allow physicians that are part of the hospital's medical staff but are not directly employed to be eligible for hospital wellness programs, benefits, and services. This way, hospitals and other health facilities can offer mental health services, counseling and suicide prevention programs, and substance use disorder treatment to all of our healthcare workforce. This is an easy fix to make sure we can make important investments in the mental health and wellness of our healthcare professionals. Mr. Chairman, I yield back.
Thank the gentleman. Let me recognize the gentleman from Pennsylvania, Mr. Kelly, to strike the last word.
Thank you, Mr. Chairman. I just take a moment to speak on this a little bit. Mr. Higgins and myself have been working on this piece of legislation, and he's already brought it up. But I think that when we look at this, we always talk about what is it that we're talking about, why are we talking about it, and how do we choose to fix it, or what are we attempting to do. So this bill is going to ensure that doctors are taking full advantage of the opioid use tools that Congress has already passed early in 2020. Now, Congress acted at the beginning of the pandemic to ensure doctors had new tools to treat Medicare beneficiaries and seniors who were suffering from opioid addiction and opioid use disorder. One of the new covered treatments was medication-assisted treatment, which attempts to substitute a new drug. Some of these things are really hard to believe. I've never used them, so it's hard for me to do it, but buprenorphine, methadone, or more easily naltrexone, okay? So I think Brian's already talked about all this, but they use these in place of opioids. Medication-assisted treatment isn't always effective, but it has been shown to work in some cases for some patients. Unfortunately, many doctors still don't know what Congress provided for them with these new tools, meaning Medicare patients still aren't getting the treatment. And I think then, in working with Brian, I come up with an idea. So why don't we let the people who do the work actually know what tools are in their toolbox that would help people? So the Medicare Opioid Use Disorder Outreach Act directs the Department of Health and Human Services to conduct educational outreach to health care providers to increase awareness and access to opioid use disorder. This just makes sense. I mean, it's already funded. We just don't have people using it. So it's hard to understand sometimes. So why don't they know? And who didn't tell them? And so I guess we're taking a time today that actually let people know. We know we've got tools to help you. It's already funded. Why don't you go ahead and access them? So I appreciate you working with Mr. Higgins. It's always good when the Irish get together to make life easier for our fellow Americans. Thanks, Mr. Higgins. And Chairman, I yield back.
Yeah, and I appreciate the gentleman's comments. I also think that was part of Ms. Hall's presentation, that how best to access those folks who, for whatever reason, either don't know about the initiative or have not been encouraged to utilize it. So I appreciate the gentleman's comments on that. A gentleman from Illinois, Mr. Schneider, is recognized to strike the last word.
Thank you, Mr. Chairman. I do move to strike the last word.
Gentleman's recognized.
I thank you for having this markup today and bringing before this committee the transformative and bipartisan bills which will help families across our entire country. First, since I was not able to be here in person earlier, I want to take this opportunity to extend my condolences to the entire Wolorski family. Jackie was a friend and esteemed colleague and committed public servant who I had the good fortune of working with for many years. The Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act, which I'm proud to have helped to introduce, is a testament to her contributions to this committee and her decades of public service. Jackie was an ardent supporter of the maternal, infant, and early childhood home visiting program, and it is a testament to her legacy that this bipartisan bill doubles funding to the program over the next 5 years. In my state of Illinois alone, about 17,000 families benefit from the home visiting programs. With an immediate 48% increase in the MIE-CHV funding and 130% increase by 2027, I'm heartened that many more families will be able to receive these critical services in my community. More broadly, as others have noted, we have a growing mental health crisis in our country. It affects people of all ages, people living in all types of financial conditions across all types of work, people in big cities, small towns, and rural communities. As also has been noted today, the reality is that we have a system that focuses almost all of its resources on dealing with mental crises rather than promoting mental health. We need to find ways to help all Americans navigate the vagaries and vicissitudes of life. We need to invest in better understanding of how the brain works at levels similar to what we did with the understanding of the human genome. And we have to educate mental health professionals in sufficient numbers to serve the needs of all Americans. Our bipartisan mental health package that we're marking up today will improve mental health services for both Medicare beneficiaries and those with private insurance. Our effort will also raise awareness of the Behavioral Health Integration, or BHI, billing codes for healthcare practitioners in order to expand access and increase education of those services in primary care settings for improved population health outcomes. I'm proud to co-lead the Behavioral Health Integration Awareness Act with my colleagues Jason Smith and Drew Ferguson. This bill would direct the Secretary of Health and Human Services to conduct educational outreach to healthcare professionals about BHI billing codes and services covered by Medicare, to encourage their uptake, detail the eligibility requirements for patients to receive these important services, and how to bill them appropriately. The Behavioral Health Integration Awareness Act will ensure that healthcare professionals are up to date on the latest requirements and procedures for billing behavioral health services. Our hope is that this results in their ability to provide their patients with the mental health care they deserve. As I've said before, no American should go without equitable access to mental health and substance use care because of education gaps in administrative procedures and services. Mental health parity issues or lack of sufficient resources to support our healthcare providers and rising providers, including care for their well-being. I support the swift passage of this bill, and I look forward to voting for them on the House floor soon. I yield back the balance of my time.
Thank the gentleman. Let me recognize the gentleman from Kansas, Mr. Estes, to strike the last word.
Well, thank you, Mr. Chairman. You know, in Kansas and throughout the country, mental health continues to ravage families and communities, and it's tragically getting worse. In August, I sat down with hospital administrators to discuss what they are facing in our urban and rural hospitals. Not surprisingly, the state of America's mental health is one of the main concerns. Across big cities and small towns, Americans are struggling with anxiety and depression, which has been fueled by stimulants and with other substance abuse disorders. Doctors and nurses are doing everything they can to help struggling patients, but they also need common sense policies from Washington that will help the crisis and not make things worse. So today we have an opportunity to address an aspect of this crisis through a bill I've introduced with a friend and colleague, Congressman Panetta, the Fighting Stimulus and Other Substance Use Disorders Act. A report from the Kansas Bureau of Investigation has found that the price for purchasing methamphetamines on the street has drastically dropped from 2014 to 2019 due to the increased production and importation of Mexican methamphetamine. The latest numbers from my state show how horrible toll this has been. Meth accounts for almost 44% of overdose deaths in Kansas. And we've also heard from law enforcement sound alarm bells over the rising crime linked with drugs, particularly with meth. In Sedgwick County, where I live, it's reported that 70% of all drug crimes involve meth. While there is medical assistance treatment for those addicted to opioids, resources are scarce for those struggling with methamphetamines and other stimulant addiction. Earlier this year, during a Ways and Means hearing, a witness told us, "We do have contingency management, which is behavioral therapy proven to work for stimulant use disorder, for cocaines and methamphetamines, which is vastly underutilized in all of our communities across the country. So yes, we need more tools, and yes, we need to actually use the tools that our researchers and clinicians and scientists have already built for us." She went on to address the barriers to contingency management, one of which is the prohibition of using federal funds for the treatment, locking out Medicaid and Medicare patients from accessing this potentially life-saving resource. Our common sense legislation will task Health and Human Services to review evidence-based contingency management incentives so that we can remove a barrier that's shutting out patients from an effective treatment while also ensuring safeguards against fraud and abuse. This is an opportunity to help individuals in each of our communities, and I would encourage my colleagues to support this life-saving bill. With that, I yield back, Mr. Chairman.
Let me recognize the gentleman from Texas, Mr. Doggett, to strike the last word.
Thank you, Mr. Chairman. For nearly a decade, Mike Thompson has sought to add to the Medicare coverage marriage and family therapists and licensed mental health counselors, and I applaud his effort and the fact that finally he's seeing this bill move forward. It will benefit many. I continue to hear from constituents urging inclusion of these providers to help address urgent workforce needs, a crisis that has been worsened as the pandemic exacerbated and created new mental health challenges. According to Health and Human Services, There are over 6,000 different areas within the United States that have mental health professional shortages, with about half of our population in America living in a shortage area. There are nearly 8,000 new professionals that are needed to fill this gap. I believe that more work will be needed by this committee to improve training and retention of additional mental health providers, including by addressing their own mental wellness needs from burnout and the like. Far too many are experiencing that burnout as demand for their services has grown so urgent during the pandemic, and the crises that so many face become more and more serious. While I commend the inclusion of Mr. Thompson's legislation, this overall package with which his bill has been strangely bundled is somewhat concerning. The modest education campaigns from other provisions are fine, but they could have been achieved through a letter or a phone call to CMS. There's no indication the administration has ever declined to do this, nor that a request has been made to them to deal with the specific issues in this bill. And assuring that employers can provide mental health services to their own physicians, as Mr. Baird described earlier, is important as we work to better address burnout and provider wellness. But most troubling, this bill also contains a provision requiring the Inspector General to examine a policy with which I have serious reservations. I think there's seldom a meeting I go to with different groups of health providers that I don't hear Mr. Stark's name invoked with something of the respect shown for the devil. Mr. Stark once sat in this chair as the ranking member and the chair at different times of the Health Subcommittee. He was responsible for the Stark laws and the anti-kickback statute. They were written to protect Medicare from rampant fraud, waste, and abuse, and there was plenty of it from kickbacks before the Stark laws were enacted. Providers from various groups have continued to lobby for one carve-out after another. As Pete put it, every shyster and promoter sought a loophole. We now have to keep rewriting the laws just like as if it were the tax code. And just as I've been concerned about loopholes in our tax code and tax fairness, I oppose similar loopholes in our healthcare system that only siphon off taxpayer dollars and deepen inequities. There may well be some benefit to the contingency management incentives that are suggested by this bill, but I question the appropriateness of cash payments, gift cards, and other incentives paid for through Medicare, and I worry about deceptive and misleading marketing. There is also a potential for misuse and engagement, particularly by pharmaceutical manufacturers. They're the ones who caused the substance use disorder crisis that has plagued our nation, and this legislation now purports to address. After incentivizing the overprescribing of opioids, Big Pharma is now benefiting from the profits off the overdose reversal drug naloxone and medication-assisted treatment. I'm deeply troubled that Big Pharma could offer contingency management incentives to steer patients into certain treatment programs and medications for a company's gain. I'd be surprised if the Inspector General would ultimately recommend such a scheme, but approval of this legislation suggests that Congress supports another Stark law carve-out that may be manipulated by some providers in Big Pharma. I don't support this provision, and I hope that it will be removed from the overall package before we have full consideration. Mr. Chairman, I yield back.
The gentleman from North Carolina, Dr. Murphy, is recognized.
Thank you, Mr. Chairman. I move to strike the last
Gentleman's
word.
recognized.
We all know that Medicare's eligibility really starts at age 65 unless there's some disability issues with it. I completely support all that we are trying to do for mental health. It is tragic that, especially what's happening in every avenue in this nation, especially since after forced lockdowns and everything over the last 2 years, it's truly, truly troubling. I see the opioid crisis. I've known 9 young children, or young men rather, who have died from the opioid crisis over the last several years, and I'm appreciative of the bipartisan work that we are doing here to help address that in improving our behavioral and mental health services throughout the country. However, I think we have to also be concerned about what the big elephant in the room oftentimes with this committee is, and that's Medicare solvency. I want to state for the record that I don't believe this bill should include coverage of marriage and family therapist service under Medicare. I just don't believe it's appropriate. And it will add $1 billion to the cost of Medicare over the last 10 years. And I have to say, a little bit tongue-in-cheek, when I first heard about this provision, my mind immediately went to Seinfeld and to Frank and Estelle Costanza. Now, we know that couples live together for years and years and years, and it's sometimes a love-hate relationship. But I think if Medicare paid for Frank and Estelle to have family counseling, it would entirely put the entire nation in Medicare and insolvency. I say that again, tongue-in-cheek, because I know that this can be a problem for couples over the age 65. But again, I look at appropriateness. I don't want to downplay that issue, but I just think about appropriateness for what we as Americans and what we as this committee should recommend to our colleagues on what Medicare should pay for. I'm sympathetic to this. I do think, however, we also have to look, we were talking about physician burnout just a few minutes ago. Psychiatrists are in dire, dire shortage in this country right now. We're not going to get psychiatrists to come out of the woodwork, or psychologists for that matter, to take care of individuals. This is a part. Medicare is not meant to take over every health care need, and this is, again, part of personal responsibility that I don't believe the government needs to get into. So it's for that fact I'm asking, I'm not supportive of this particular provision in the bill. Thank you, Mr. Chairman, and with that, I will yield back.
Thank the gentleman. Let me recognize the gentleman from Pennsylvania, Mr. Schmucker, to strike the last word.
Thank you, Mr. Chairman. And let me just start by, again, thanking the chairman for holding this hearing today and for working together in a bipartisan way to really make a difference in the lives of the people that we represent. It's really refreshing to see this committee work together in that way, and I hope that we see more of this. So thank you, Mr. Chairman. The COVID-19 pandemic exacerbated many mental health challenges that our nation faces, especially those regarding substance abuse. And we've all seen that in our communities. It's tough to find a family that hasn't been impacted in some way, may have lost someone, or at least, or have friends of theirs have been impacted. Around 21,000 of my constituents face substance abuse challenges every day. And I think the sometimes lack of mental health support, tragically, individuals tend to turn to drugs when they can't access that help that they need. So the package of bills that we're discussing today takes common sense steps to closing that access gap and helping patients access the care when they're struggling. Congress has taken steps in the past to cover mental health and substance abuse care services under Medicare. That's been talked about here. But we find that despite that coverage, those services are not reaching patients at the rate that they should. For example, HHS the Inspector General found that less than 16% of Medicare beneficiaries diagnosed with opioid use disorder receive medication-assisted treatment, with even fewer receiving behavioral therapy. So that's why I'm so supportive of the bills under this committee print, which will help to improve outreach to providers and patients about the behavioral and opioid use treatment options that are already available under Medicare. It's my hope that greater awareness of the resources available will mean that more of my constituents will end up getting the care they need. So again, thank you, Mr. Chairman, and with that, I'll yield back.
Thank the gentleman. Let me recognize the gentleman from California, Mr. Panetta, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word.
Gentleman's recognized.
Thank you. Mr. Chairman, let me take this time to briefly express my deepest condolences to the family of former Representative Jackie Wolorski, her friends, her staff as well. I always found Representative Wolorski to be a member's member, in that, similar to most members of this committee, she would rather talk about policies than politics and the people of her district rather than her party. I say that based on the work that I did with her personally on the Qualified Improvement Properties Bill, or otherwise known as Restoring Investment and Improvements Act, which we were able to pass to ensure that small businesses were able to get the right returns on their investment in their businesses. And then also on the Preserving Family Farms Act, so that our local farmers could ensure the proper value of their property if sold. And so I know that Jackie will be missed, clearly, but her legacy lives on with the legislation we passed today out of this committee, but more importantly with the people that she represented in Indiana. Now, Mr. Chairman, in my district on the Central Coast of California, like we've heard today, clearly there's an addiction and mental health crisis, as we've seen. That's why the Fighting Stimulant and Other Substance Use Disorders Act addresses this crisis by letting the Department of Health and Human Services consider contingency management intervention. It's this type of intervention that has been a proven tool and can incentivize drug treatment by rewarding patients for recovery milestones. This science-based bill will help the people from Carmel to Kansas, all across this country, overcome addiction and lead fuller and more productive lives. I want to thank my colleague, Congressman Ron Estes, for his leadership on this issue, and I do ask the committee to support this important bill. And briefly, Mr. Chairman, I ask unanimous consent to submit for the record a statement in support of the FIT Act, P-H-I-T, a bipartisan bill of which I am a co-sponsor to address physical and mental health, and I urge my colleagues to consider this important legislation as we approach the end of the year business.
So ordered.
Thank you, Mr. Chairman. I yield back.
Thank the gentleman. I believe there are no amendments. Therefore, the question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Opposed,
Aye.
no. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. Now let me recognize Mr. Thompson for the purpose of offering a motion.
Mr. Chairman, I move that the committee agree to Committee Print 117-2 as amended.
The question is on agreeing to the committee print 117-2 as amended. Members are reminded to unmute themselves for a voice vote. All those in favor signify by saying aye.
Aye.
Those opposed, no. In the opinion of the chair, the ayes have it. The motion passes, and the committee print 117-2 as amended is agreed to. The next order of business is the committee print 117-3. Requiring coverage of forensic medical exams with no cost sharing. This bipartisan committee print makes important steps to protect victims of sexual assault with private insurance receiving forensic medical exams from cost sharing and surprise medical bills at the time of trauma. I think we can all agree that this is an important endeavor. The last thing that a victim of sexual assault should have to deal with is juggling bills and out-of-pocket expenses associated with their care. A March study by the Kaiser Family Foundation found that 2/3 of privately insured women who likely received a forensic exam after a sexual assault were charged out of pocket for at least one standard service included in that exam. We have tremendous advancements that have been made in the No Surprises Act to protect consumers, and today we are building on that progress. Survivors grappling with trauma should not also have to grapple with cost burdens. I want to thank Ms. Sanchez, Ms. Moore, and Ms. Miller for their efforts on this legislation. I now recognize Mr. Brady for the purpose of an opening statement.
Thank you, Mr. Chairman. This committee print does include the No Surprises for Survivors Act. I want to thank Representative Carol Miller as well as Representative Sanchez and Moore for your really great work on this important bill. Protect victims from bills they shouldn't have to face. This is good legislation and a great issue that I'm glad this committee is working on. Far too often, as we know, victims of sexual assault don't or can't seek out the exams and treatments that they need after the assault. This bill takes away one such barrier and impediment to getting that care. Proud to build on the success of our committee's work to protect patients from surprise medical bills by ensuring that victims receive the compassion and care they deserve without fear of facing a surprise bill. Mr. Chairman.
Thank you, Mr. Brady. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute, which has been distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. Now, let me turn to Amy Hall, Staff Director for the Subcommittee on Health, to provide technical description of the amendment in the nature of a substitute with an emphasis on changes made since notice. I ask that members hold their questions until after Ms. Hall's presentation.
Committee Print 117-3, requiring coverage of forensic medical exams with no cost sharing. Amends the Public Health Service Act, the Internal Revenue Code, and the Employee Retirement Income Security Act to, number 1, require coverage of forensic medical exams with no cost sharing. 2, ensure that individuals receiving forensic medical exams do not receive surprise medical bills. And 3, streamlining the reimbursement process where applicable. The amendment in the nature of a substitute makes the following change. On page 11, line 6, it inserts a semicolon after the word individual. That concludes my walkthrough, and I am happy to answer any questions.
Thank you. We will now proceed to the question stage. Are there any questions about the amendment in the nature of a substitute? The gentleman from Texas, Mr. Doggett, is recognized.
Thank you, Mr. Chairman. Agreeing fully with you that at the time of greatest need, no one should be faced with a surprise bill. Let me ask you about the scope, Ms. Hall, of this bill. If there is a need for laceration repair as a result of a sexual assault, can the person be exposed to a surprise medical bill, or are they protected by this legislation?
Mr. Doggett, excuse me, I would like to get back to you with an affirmative answer. The definition of a forensic medical exam for the purposes of this legislation is examination for physical trauma, a determination of penetration or force, interview with such an individual, and the collection and evaluation of evidence. So, but I actually do want to get back to you because I think you're
Thank you. I welcome your getting back. Having read that, it does not appear that exam covers treatment, and that's my inquiry. I would hope that you could cover that, could cover the kind of problems that might arise from somebody being assaulted and exposed to sexually transmitted diseases and the like before this measure gets to the floor. It's one of the things that I wish could have been improved before we got here. Also, since this is a mental health bill, and there were recommendations from the Legal Action Center in our previous hearing about that, do you provide any protection here against surprise medical bills for mental health care for a survivor of sexual assault?
The ordinary surprise billing protections for mental health care would remain regardless of what reason a person was seeking that care.
Okay. Well, you provide special provision by this legislation for forensic exams, but it does not include mental health.
So what I'm, I think, inartfully trying to say, Mr. Doggett, is that to the extent surprise billing protections apply for mental health care that is sought by an individual, regardless of the reason, there's no change in that, right? So if a person sought mental health treatment in an emergency at an out-of-network provider, right, surprise billing protections would apply in that instance. It wouldn't matter what reason the person was seeking the treatment.
The Legal Action Center, for example, asked that we prohibit surprise medical bills for mental health treatment when there was not care readily available in network. That's not covered here, is it?
So I think I'm doing a poor job of explaining. I'm sorry.
Well, you can follow up if you wish.
I'm happy to follow up with you. I'm not trying to be difficult, but I think that in
I'm sure you're not.
Many circumstances, the answer to your question is yes, surprise billing protections apply. I think there's potentially some narrow instances where it might not, but I'd like to follow up with you.
Okay. Let me ask you about one broad one then, in closing, that after we got belatedly the bill draft we raised, and that's the question of domestic violence survivors, because they also can face unique circumstances like this and may require a forensic medical exam. DOD has a definition that I forwarded to you. There's one through the Indian Health Services. Why were domestic violence survivors excluded from this measure?
So the legislation, as you know, focuses on sexual assault survivors. This comes from, I think this bipartisan idea comes from some research done by the Kaiser Family Foundation. They have an entire report from, let's see, from earlier this year, that identified particular issues related to sexual assault. We have heard from both the sponsors of the bill about trying to talk further about how that might be incorporated. We will continue to work on a bipartisan basis on that issue as we go forward, and I think the chairman and Mr. Brady alluded to that as well, generally speaking, that we're going to continue to work on this legislation. So.
Well, I know we're going to continue to work on the legislation, but specifically domestic violence survivors ought not to be excluded. And again, had we received this measure timely, we might well have been able to prepare an amendment to resolve that today. But I'm hopeful that we can work on it before it reaches the floor. Thank you.
Are there any other questions in the nature of the substitute? Does anyone wish to strike the last word?
Mr. Chairman?
Yes. Ms. Sanchez is recognized to strike the last word. Pardon?
Thank you, Mr. Chairman. Thank you for bringing forward this important committee print. This provision is based on my bill, the No Surprises for Survivor Act, which I introduced with my colleague, Reps. Gwen Moore and Representative Carol Miller. We know that sexual assault is a traumatic experience that can have lasting impacts on an individual's mental and physical well-being. And forensic medical exams, commonly known as rape kits, are basic services that survivors need to receive follow-up medical care and pursue justice. Unfortunately, despite the goals of the Violence Against Women Act, thousands of women with private health insurance still face hundreds of dollars in costs for this very basic exam. In one analysis, the Kaiser Family Foundation found that on average, women with private insurance faced $466 in cost sharing for services that are part of a forensic medical exam. Cost barriers should not prevent survivors from seeking the care and the support that they need. That's why this bipartisan bill requires private health plans cover the full cost of rape kits or help streamline the reimbursement process through state channels. It also ensures the women and other survivors have access to a broader range of healthcare providers in these emergencies without having to pay out of pocket or face surprise medical bills. This committee print takes significant steps to reduce cost barriers for survivors, and I was proud to work with my colleagues on this committee to advance this proposal. I'd also like to recognize the work that both my Democratic and Republican colleagues have done to reach a bipartisan consensus on reauthorizing the Maternal, Infant, and Early Childhood Home Visiting Mcv Program. And I'm also proud that we are honoring our late colleague, Jackie Wolorski, who we all dearly miss. I know that Chairman Davis had a strong partner in Representative Wolorski, who shared his commitment to combating child poverty. The pandemic spurred us into action to significantly reduce child poverty through the American Rescue Plan's temporary expansion of Mcv and other anti-poverty programs like the Child Tax Credit. The Mcv program in particular has prevented many families in my district and in the Los Angeles area from falling through the cracks during the pandemic. But much work remains to be done to put more families on solid footing. The Jackie Wolorski Maternal and Child Home Visiting Reauthorization Act will ensure these resources reach more struggling families in California, and it will help to address historic inequities, provide flexibilities for working families, and expand access to this critical program. I want to thank the chairman again, and I yield back the balance of my time.
Thank the gentlelady, and I hope she's feeling better. And with that, let me recognize the gentlelady from West Virginia, Ms. Miller, to strike the last word.
I move to strike the last word.
Gentlelady's recognized.
Thank you, Chairman Neal and Ranking Member Brady. I rise today in support of Committee Print Number 3, which contains my bill, the No Surprises for Survivors Act. I especially want to thank Congresswoman Linda Sanchez and Congresswoman Gwen Moore for working with me on this important legislation. I am so pleased that all of my colleagues have come together to address the many challenges of mental health. Our bill helps to ensure that victims of sexual assault who have private insurance are protected from out-of-pocket costs or any surprise medical bills related to their forensic medical exam, otherwise known as rape kits. Sexual assault is one of the most abhorrent acts of violence that a woman can experience. It is unacceptable for any sexual assault victim to receive a bill for a forensic medical exam. Now, this exam is critical to determining what needs to happen and ensuring their recovery, as well as collecting any evidence that is needed for the investigation. This bipartisan bill will protect victims and ensure that no woman who experiences sexual violence has to pay a dime for a forensic medical exam. I urge my colleagues to support this committee print, and I yield back. Thank you.
Thank the gentlelady. Let me recognize the gentlelady from Wisconsin, Ms. Moore, to strike the last word.
Thank you so very, very much, Mr. Chairman. One of the things that you learn when you've been a legislator for a long time is that when you have the votes, you don't talk much. So I am going to be very, very brief and I'm not going to repeat some of the important things that have already been said by my fantastic co-sponsors, Linda Sanchez and Carol Miller. So happy that we've been able to bring this forward. I do want to make note of the inquiries that our colleague, Mr. Doggett, has made, and to say that we welcome a further examination of this, amendments as necessary, because it's definitely our intent to include domestic violence victims as well. He made a very, very cogent point about the other sort of costs that could be incurred from a sexual assault, other kinds of injuries. And again, that just re-victimizes someone when they get a bill for the $400, $450 for the rape kit, and then another bill for other medical attention that they need associated with a violent rape. And so I just want to thank Mr. Doggett for his diligence with regard to raising that point. There's another point that hasn't been raised yet, and so I will take a couple more seconds to lift up the provision in this legislation that would enable other providers, other than sexual assault nurses, to collect the forensic material. I think that would hinder anyone's care. Who knows when and where you're going to be sexually assaulted, to show up at your local hospital and a regular doctor or a regular emergency room nurse couldn't do that. That's an unnecessary hindrance. So I am really happy that provision is included as well. I thank you so much, and I would yield back the balance of my time.
I thank the gentlelady. I don't believe there are any other requests to strike the last word.
I'm striking the last word on.
You would like
Yes.
to proceed again? Yeah, fair. Yeah. The gentleman from Texas is recognized.
I was on questions.
Oh, you want to go to?
This is just on striking the last word.
You want to strike the last word?
Yes.
The gentleman is recognized to strike the last word.
Thank you very much, Mr. Chairman, for the clarification, and I particularly appreciate the comments that Ms. Moore just made. I know that had you and Ms. Sanchez and others who were given this responsibility for a draft-written proposal on Monday or shortly before, if we'd had thorough consideration of this, we could have resolved these issues before the markup, and that's all that I'm really asking for. I think you have a basically good proposal. I think it could be dramatically improved to be sure that since the goal is to protect victims of sexual assault, that we protect them fully and not just for the forensic exam. And then secondly, there is this problem about domestic violence. This could have been easily included here. There was a definition. Even though I got this at the last minute, I sent that over, but we could not get consideration of that to include in today's bill, nor really the time to fully draft an amendment. But I hope that we can come to some understanding as this comes to the floor. The Violence Against Women Act was intended to protect survivors from charges for evidence gathering portion of their care, but some are still erroneously billed. Exams are not always performed by in-network providers, and VAWA does not guarantee coverage for associated medical care, such as diagnostic tests, laceration repair that I was asking about, counseling, sexually transmitted disease and infection treatment, and sometimes emergency contraception. Today's legislation will assure survivors do not receive surprise medical bills for the evidence-gathering portion, but not for the other issues. No rape survivor should bear the financial burden of medical care during their greatest hour of need. I'm pleased to support this bill to provide greater protection for survivors, but want to see it cover all of their needs. Last week, I stood with the National Domestic Violence Hotline to celebrate over 25 years of life-saving and life-changing support currently headed by CEO Katie Ray Jones. They've answered over 6 million contacts, and it would be so helpful if this, what is really not just a hotline, but a hope line, were able to know that not only do you have the exam, but the treatment that is necessary to make that known to someone who's the victim of domestic violence. One of the supports that could have been provided through the hotline and through other services for those who are victims of domestic violence is the protection that I'm seeking in this bill. So I hope we can work together with the domestic violence groups like the Texas Council on Family Violence and the hotline and the Safe Alliance to see that we provide a solution for victims of sexual assault and for domestic violence in the course of this legislation. And with that, I yield back, Mr. Chairman.
Gentlemen, let me recognize the gentleman from Pennsylvania, Mr. Kelly, to strike the last word.
Thank you, Mr. Chairman. I'd like to strike the last word. Mr. Panetta briefly talked about this, but there's another piece that I think we need to consider at our end-of-the-year discussion, and that's the FIT Act. Mr. Kind is also on that, and so is Ms. Sewell. I just think the FIT Act needs to be something that is included, because if you would see the support for this, there's over 4,000 youth sports organizations, the U.S. Conference of Mayors, the National Football League, Major League Baseball, National Basketball Association, and the National Hockey League commissioners have all lent their voice to the FIT Act. They, like the rest of us here, are concerned that a sedentary lifestyle is negatively affecting our youth. Now, this isn't just a physical health issue. Exercise and healthy lifestyles also lead to improvements in mental health, which our children so desperately need. I don't think in the last couple of years that our youth have had the opportunity to work with other people with common goals, and that usually comes through some type of an athletic event, which doesn't have to be limited to that, but is really a big part of growing up, whether you're in Little League, Pony League, American Legion Baseball, whatever it is that you choose to participate in. Working with other people to achieve common goals, I think, are essential, especially to our youth. So with that in mind, Chairman, I'd like to request for unanimous consent to enter into the record this letter, which I referred to earlier, that's by every possible supporter of athletics. So what? Okay, then I yield back. Thank you.
Thank the gentleman. I don't think anybody else has requested to strike the last word. And I don't think there have been any amendments that have been suggested or offered. So let me proceed by moving to Mr. Thompson.
Mr. Chairman, I move that the committee agree to committee print 117-3 as amended.
Yeah. So I will also go back and disqualify that, even though Mr. Thompson has appropriately served his responsibility. There are no amendments. The question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no.
Aye.
The opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. Mr. Thompson, do you want to reiterate what you just said?
Do I get paid twice?
You do.
Mr. Chairman, I move that the committee agree to committee print 117-3 as amended.
The question is on agreeing to the committee print 117-3 as amended. Members are reminded to unmute themselves for a voice vote. All those in favor signify by saying aye. Aye. Those opposed, no.
Aye. Aye.
In the opinion of the chair, the ayes have it. The motion passes, and committee print 117-3 as amended is agreed to. Now, let me point out that we still have 2 more sections to get through here, and there are 4 votes that are pending. So we will proceed now, as the next order of business, to committee print 117-4, the improved information in provider directories, plan definitions, and crisis services for private insurance plans. Committee print 117-4 includes 3 important policies to promote transparency and access to care for individuals with private insurance. First, the legislation would ensure that provider directories include updated information on whether a provider is accepting new patients, including telehealth or in-person visits. Second, the legislation ensures that mental health and substance use disorder benefits are defined pursuant to nationally recognized standards. This will promote greater certainty and help consumers better understand what benefits are covered with their plans. Finally, the committee in print requires the Secretary of Health and Human Services, Labor, and Treasury to conduct outreach related to the availability of mental health and substance use disorder crisis services. We must fight stigma and ensure that patients are aware of and comfortable in accessing care in a time of need, particularly in crisis. These provisions build upon the important work relating to the healthcare transparency that this committee began on a bipartisan basis in the surprise billing legislation. The easier we can make it for consumers to understand what providers and services are available to them, especially when it comes to mental health and substance use disorder treatments, the better we can ensure patients receive necessary care. I want to thank Mr. Kildee, Dr. Winstrup, Ms. Moore, Mr. Hearn, Mr. Schweikert, Ms. Sewell, Mr. LaHood, and Mr. Kustoff for their contributions to this measure. Now, let me recognize Mr. Brady for the purpose of an opening statement.
Thank you, Mr. Chairman. This print does include 3 bills that all aim to improve the transparency of coverage for the 180 million Americans who get their care in the private health insurance market. The Better Healthcare Directories Act gives patients more information about which providers in their network are accepting new patients and eases access to care. I, too, would like to thank Representatives Winstrup and Hearn, along with Representative Kildee, for their great work to build on what I think is excellent work in the Surprise Medical Billing Act that we led, improving the accuracy of provider directories that patients use to find a doctor in their network. The Promoting Clarity in Mental Health and Substance Use Disorder Treatment Act was introduced by Representatives Moore and Schweikert. This bill makes it easier for patients to compare and contrast the mental health benefits offered by different plans and pick the right plan that suits their needs. And finally, the Access to Mental Health Services Act ensures that patients experiencing a mental health crisis understand the critical protections offered by the No Surprises Act that this committee got signed into law last Congress. So thank you here to Representatives LaHood, Kustoff, and Sewell for your great work on this legislation. Chairman?
Thank the gentleman. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. Let me turn again to Amy Hall, the Staff Director for the Subcommittee on Health, to provide technical description of the amendment in the nature of a substitute with an emphasis on the changes made since notice. I ask members to hold their questions until after her presentation. Ms. Hall.
Committee Print 117-4, Improved Information in Provider Directories, Plan Definitions, and Crisis Services for Private Insurance. Section 1 amends the Public Health Service Act, the Employee Retirement Income Security Act, and the Internal Revenue Code, building on the surprise billing law to require that provider directories specify whether providers are accepting new patients, including via telehealth or in person. Section 2 requires plans to use standard definitions in their mental health and substance use disorder benefit descriptions that comport with the World Health Organization's International Classification of Diseases and Related Health Problems, or that is listed in the most recent version of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders for plan years beginning after enactment. Section 3 requires the Secretaries of Treasury, Labor, and Health and Human Services to conduct outreach regarding the availability and importance of mental health crisis services, as well as to report to Congress by January of 2024 on mental health crisis services and barriers to accessing those services. The amendment in the nature of a substitute makes the following change. On page 5, line 7, insert a comma after 2025. That concludes my walkthrough, and I am happy to answer any questions.
Thank you, Ms. Hall. Are there any questions about the amendment in the nature of a substitute?
Mr. Chairman, in view of the votes that are pending on the floor, I will reserve my questions.
I can't tell you how grateful we are. I want to thank the gentleman. Does anyone is there anybody else that wishes to? Yes. Mr. LaHood, you want to strike the last word?
Yes, please.
Why don't we do that?
Thank you, Mr. Chairman. I would like to strike the last word. Mr. Chairman and Ranking Member Brady, thank you. I'm pleased to join my colleagues, Representative Terry Sewell and Representative David Kustoff, in introducing this important bipartisan piece of legislation, H.R. 8892, the Access to Mental Health Services Act of 2022. As we've all seen, the mental and behavioral health needs across our districts have grown exponentially over the last several years, particularly for children, veterans, healthcare workers, rural communities during our COVID-19 pandemic. Moving forward, it is critical that we all do what we can to ensure patients better understand their choices and access to mental health crisis services. I represent the 18th District of Illinois, which is a rural district where access to health care can be a challenge for many of my constituents. Lack of rural broadband can limit much-needed telehealth and telemedicine, and recruiting qualified mental health providers for adults, families, and children remains difficult. I am proud that the healthcare providers in my district are working to address these gaps in care. As one example, Unity Point Health in Peoria, in my district, recently received federal funding to open a new child and adolescent behavioral health center to provide quality mental health services for children in central and west central Illinois. Now, while we continue to support investment and access to mental and behavioral health resources, we must also make sure to limit any barriers for access to this care. That is why this bill is so important. This bill directs the Departments of Health and Human Services, Labor, and Treasury to expand outreach and education efforts and identify barriers to mental health crisis services. This will allow providers to better treat patients, increase access, reduce stigma, and limit any barriers to care. The bill will also broaden provider and patient education on where and how to access mental health care services in a crisis, as well as protect patients and providers from any surprise medical bills. The bipartisan success spearheaded by this committee last Congress to address surprise medical bills has helped my constituents greatly, and we should build upon this success by ensuring providers and patients have the resources they need, particularly in the mental health crisis, to find access and to receive treatment. Once again, I'm proud to join my colleagues in introducing H.R. 8892, a much-needed piece of legislation to address our mental health and behavioral crisis, and I urge my colleagues to support its passage out of committee today. Thank you, and I yield back.
Thank the gentleman. Let me recognize the gentleman from Texas to strike the last word.
Thank you, Mr. Chairman. Too often, consumers find that providers have either dropped out of their network or they don't have any appointments. While appointment availability and plan provider contracts are frequently changing, so much more can be done to try and improve the accuracy of these directories. This legislation takes a modest first step by requiring providers to inform plans at least annually whether they're accepting new patients and whether they offer in-person or telehealth services. I'd like to see it done much more frequently than 1 year with all the electronic ability we have now, but at least this is progress in the right direction. I also strongly support the bill the staff assigned to Ms. Moore and to Mr. Schweikert that standardizes coverage requirements across plans. I think this is important to ensure that all consumers receive comprehensive coverage for mental health and substance use disorder services. Currently, plans may define these benefits differently, leading to some consumers losing out on essential treatment. This legislation from Ms. Moore and Mr. Schweikert aligns coverage requirements with medical guidelines for the full range of services. Standardizing these benefits is an important consumer protection tool to prevent patients from fighting with their plans for coverage approval of very necessary treatment. Finally, while I have some questions as to how a consumer education campaign will be implemented, I support the provision in this bill that would work to inform patients of available mental health and substance use disorder crisis services. Coverage for such services is ineffective if patients don't know they are available and how they can use the benefits. Though largely modest, this package represents some progress in improving consumer information and access to mental health benefits, and I yield back.
Thank the gentleman. Let me recognize Dr. Winstrup to strike the last word.
Thank you, Mr. Chairman. I'd like to move to strike the last word.
I want to thank my colleagues, Representative Kildee and Hearn, for working with me on this legislation. This committee worked diligently on landmark transparency measures as we played a key role in drafting legislation to ban surprise medical billing. Part of this was a bill Congressman Larson and I championed that was eventually passed into law, requiring insurance companies keep robust, up-to-date provider directories. As a doctor, I sometimes had patients that would come to the office and very upset because their insurance company had said that our practice and I were in their network, and they were not, and it had been several years. So that's a position I don't want to see patients in. We're building off that important work today by continuing the bipartisan efforts in this committee to put patients in the driver's seat of their health care. The Better Healthcare Directories Act will ensure patients know if the providers in their network are taking new patients and if telehealth appointments are available. So I encourage my colleagues to support this legislation so we can further empower patients with tools they need to make the best health care decisions for themselves. I yield back.
I thank the gentleman. Let me recognize the gentleman from Michigan, Mr. Kildee, to strike the last word.
Thank you, Mr. Chairman. I offer my strong support for this legislation, which includes the Better Directories Act, which is my friend Mr. Wenstrup referenced. I introduced with Mr. Wenstrup and Mr. Hearn. Simply put, Mr. Chairman, this bill will make it easier for people to access health care. This legislation would ensure that private insurance plans regularly update their health care provider directories. It would also make sure that these directories include whether a provider is accepting new patients, as well as whether a provider offers in-person or telehealth appointments. In recent years, Consumer Reports have shown that lists of providers maintained by insurance plans are riddled with inaccuracies. Errors have included inaccurate phone numbers, mislabeling, whether a provider was in-network, even if a provider is accepting new patients. This leads to significant delays and frustration for consumers, as well as preventing them from accessing health care services. I hear about the struggle the most when people are trying to find a mental health provider. We know many, many more people struggle with mental health issues alone, rather than seeking help. Everyone deserves access to high-quality, affordable health care, including mental health care. Unfortunately, there are just too many barriers preventing people from accessing the services that they need. It can be a huge undertaking to find a mental health provider, especially when you might be in a health crisis. My bill, this legislation, will help diminish this barrier and make it easier for people to find and access the care they need. By holding private insurance companies and healthcare providers accountable, we're creating greater transparency and a more direct path to healthcare services for patients. I urge my colleagues to support this legislation because it will streamline the process of selecting a provider and make it easier for patients to access vital healthcare services. Thank you, Mr. Chairman. I yield back.
Thank the gentleman. The gentlelady from Wisconsin is recognized to strike the last word.
Thank you so very, very much, Mr. Chairman, for scheduling this bill today. I move to strike the last word. Sorry.
Gentlelady is recognized.
Thank you so much, Mr. Chairman. I just want to thank you for advancing this bill today, the Promoting Clarity on Mental Health and Substance Use Disorder. I also want to really thank my colleague across the aisle, Mr. Schweikert, for his leadership on this really important bipartisan legislation. I also want to lift up Patrick Kennedy. Mr. Chairman, you mentioned him earlier about his long struggle to get mental health parity on our books. And so this is a victory for him today as well. Many people are plagued by mental disorders, and substance abuse disorders are appropriately deemed to be mental health disorders as well. But yet, those folk don't necessarily get the kind of treatment that they need. And so this bill does exactly what the title says that it does, that it promotes clarity in mental health and substance abuse disorders so that insurance companies and the doctors and treatment providers will be reimbursed for the services that they provide based on consistent and clear definitions, and that they're aligned nationally and internationally with recognized treatment standards. So thank you again, Mr. Chairman, Mr. Schweikert, and members for providing this needed clarity, and I hope that this is going to further reduce barriers to effective treatment for those who need it. And that was the whole goal of the mental health parity legislation in the first place. And with that, I yield back the balance of my time.
Thank the gentlelady. Let me recognize the gentlelady from Alabama, Ms. Sewell, to strike the last word.
Mr. Chairman, thank you so much. I move to strike the last word.
Gentlelady's recognized.
Earlier this week, I was proud to introduce, and today this committee is now taking up as part of this package of the bill that deals directly with mental health services. It's called the Access to Mental Health Services Act. This bill enhances and further promotes outreach efforts and access to mental health and substance abuse disorder crisis service under private insurance plans. I'd like to thank my Republican colleagues for joining me in this effort, Representative LaHood as well as Kustoff for their partnership in helping to remove the stigma that too often is associated with obtaining mental health services. The truth is that many do not have access to such services. They may not know where to access them or fear the perception of needing help. To my colleagues and friends that feel this way, to our neighbors and friends, I say we see you, we hear you, and you are not alone in this fight. I want to thank the committee staff for their work on this legislation, today's markup, and commitment to urging that help remains an option for all Americans. With that, Mr. Chairman, I yield back.
I don't believe there are any other requests for striking the last word, the result of which is we will proceed to the amendment stage, which I believe that there are no proposed amendments as well. So let me recognize Mr. Thompson. No, hold on. All those, we going to this first? If there are no amendments on the question of the adoption of the amendment in the nature of a substitute, please all of those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it. And the amendment in the nature of a substitute is agreed to. Let me recognize Mr. Thompson.
Mr. Chairman, I move that the committee agrees to Committee Print 117-4 as amended.
All those in favor signify by saying aye. Aye. Those opposed signify by saying no. In the opinion of the chair, the ayes have it. The motion passes, and the committee print 117-4's amendment is agreed to. Now, we will try, based upon the floor schedule, to get through 1175, the final order of business, the improved information for network coverage and plan documents and private insurance plans. This committee print includes two important policies further improving transparency to assist consumers with private insurance and accessing mental health and substance use disorder benefits. First, it would have the Secretaries of Health and Human Service, Treasury, and Labor work to develop a methodology to display the robustness of plan provider mental health and substance use disorder networks so that consumers can make informed choices when accessing care. Second, it would require public posting in a machine-readable format of summary as to benefits and coverage explanations. These provisions build upon the important work relating to healthcare transparency that this committee began on a bipartisan basis in the surprise billing legislation. By promoting a greater understanding of the breadth of provider networks as well as covered benefits, we can empower consumers to have a greater awareness of what their health coverage can do for them. At the end of the day, transparency is worthwhile when we shine a light on an issue and make information easy to find. I want to thank Mr. Horsford, Mr. Buchanan, Ms. Plaskett, Mr. Rice, and Mr. Schmucker for their contributions to these provisions. Now, let me recognize Mr. Brady for the purpose of an opening statement.
Thank you, Chairman. This bill continues our work on transparency in healthcare with two bills that arm patients with more information about their coverage. First, Representative Buchanan and Representative Horsford have brought forward the Mental Health Transparency Act, which will give patients information on just how robust their plan's network is with respect to mental health providers. Second, the Readable Insurance Coverage Enhancement Act, or the RICE Act, will create a way for app developers and nonprofits to get patients more information about their plan's mental health and substance use disorder benefits. Thanks to Representative Rice, Smucker, and Plaskett for your work on this initiative. Look forward to working with you, Chairman, on these bills out of committee.
Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered the base text for purpose of amendment. Now, let me turn to Amy Hall, Staff Director for the Subcommittee on Health, to provide a technical description of the amendment in the nature of a substitute with an emphasis on changes made since notice. I ask that members hold their questions until after her presentation.
Committee Print 117-5, Improved Information for Network Coverage and Plan Documents in Private Insurance Plans. Section 1 requires the Secretary of Treasury, the Secretary of Health and Human Services, and the Secretary of Labor to work together to develop a framework for indicators related to network participation for mental health and substance use disorder providers. Section 2 requires plans to submit to the Secretary and have the Secretary post publicly the summary of coverage and benefits in a machine-readable format. The amendment in the nature of a substitute makes the following change. On page 11, line 4, insert a comma after the word separately. That concludes my walkthrough. I am happy to answer any questions.
Thank the gentlelady. Are there any questions about the amendment in the nature of a substitute?
Mr. Chairman, in view of the enthusiasm with which my lack of questions was
It was
greeted
unanimous.
last time, I have no questions nor need to strike the last word.
Good. I thank the gentleman. Are there any other questions in the nature of a substitute? We will proceed then to the amendment stage, which I believe there are no amendments. Move to strike the last word, rather. Oh, yes. Let us recognize Mr. Horsford for his good work on this measure. Mr. Horsford.
Thank you. Chairman Neal, I move to strike the last word.
The gentleman's recognized.
Thank you. I was pleased to introduce the Mental Health Transparency Act with my colleague, Representative Vern Buchanan of Florida. The COVID-19 pandemic has without a doubt highlighted the importance of access to comprehensive mental health and substance use disorder services. One study from the Boston University School of Public Health indicated that the rate of depression in the U.S. tripled in the first few months of the pandemic. Since then, there has been a dramatic uptick in a number of mental health disorders, such as anxiety, and the egregious increase in drug overdose deaths that we are all privy to. These crises continue to emphasize the need to access comprehensive coverage. Our bill, the Mental Health Transparency Act, will enhance transparency and oversight regarding the number of mental health and substance use disorder providers covered under private insurance plans. It does so by developing new indicators for the provider network size, empowering consumers while they select their health insurance plan, and requiring information on plan coverage to be made publicly available. Should this bill be signed into law, patients will be able to immediately understand how good their plan is for mental health and substance use disorder services, rather than having to figure out after they have already chosen their health insurance. I'm grateful to have my Republican colleague, Representative Buchanan, on this important bill, and I look forward to the passing on the House floor. Thank you, Mr. Chairman.
Thank you for your work, Mr. Horsford. Is there anybody else who would like to move to strike the last word?
Mr. Chairman.
Mr. Rice is recognized to strike the last word.
Thank you, Mr. Chairman. I would venture to say that perhaps less than 5% of people actually read their health insurance policy, and that's for good reason, because the health insurance policies are written by teams of lawyers to make them purposefully opaque and difficult to understand. The bill, the Rice Act, which I championed but did not name, would work to try to clarify a little bit the extent of the coverage in a health insurance policy. Understanding the ins and outs of private health insurance can remain daunting for the average American. Too often, patients find out the true nature of their benefits after they're enrolled in a plan and find themselves frustrated with the system. The best way to save private insurance in the long run is to make sure we have transparency and that patients understand the benefits. Under current law, private insurers must provide a summary of benefits and coverage to help consumers compare their private insurance options. However, the summary of benefits and coverage, or SBC, is not available in a centralized location to enable researchers, nonprofits, and other stakeholders to analyze the relevant information and identify trends or potential gaps in coverage. this legislation would make it easier for app developers, researchers, and nonprofits to compile and compare this information, giving patients more available resources to give them the confidence to enroll in the plan that works best for them. I urge my colleagues to support this legislation. Thank you, Mr. Chairman. I yield back.
I thank the gentleman. I believe Ms. Plaskett would like to be recognized to strike the last word. Ms. Plaskett.
Yes, thank you, Mr. Chair. I ask to strike the last word.
Gentlelady's recognized.
Thank you so much. I'm just very excited about the work that this committee has been able to do, particularly facing mental health issues that so many Americans are now facing, and our desire to support the consumers as well as providers of mental health services. We have policy now that requires the administration to develop certain network transparency indicators that relate to the percentages of mental health and substance use disorder providers covered in-network by private insurance plans. It would also require the administration to gather a list of relevant mental health and substance use disorder providers, and this information would also be publicly disclosed. The committee has heard a number of concerns about network access when it comes to behavioral healthcare providers, and this is an important transparency. I'm honored to sponsor with Representatives Rice and Smucker a provision that would require the summary of benefits and coverage explanations, which are documents that health plans to give to consumers that outlines the benefits of what's covered by their plans and various out-of-pocket expenses. That it must be available on a public website, and the administration must write a report concerning the accessibility and comprehension for consumers of these summary of benefits and coverage explanations. This aims to promote greater transparency and help consumers with private insurance to better understand their covered benefits and their financial responsibilities. While plans are already required to provide the summary of benefits and coverage to consumers, the information is not currently in a centralized location, which could help researchers and other stakeholders analyze the benefits and identify potential gaps. I'm just very excited about the work that we're doing today, and thank you, Mr. Chairman, for bringing this hearing forward, bringing these measures for this markup, and I yield back.
I thank the gentlelady. Let me recognize the gentleman from Pennsylvania, Mr. Smucker, to strike the last word.
Thank you, Mr. Chairman. I hear it all the time. Our healthcare system is too complicated, it's too opaque, it's just difficult to understand. Now, I'm not a medical professional, but sometimes it feels like you have to be one just to purchase health insurance. I know many of my constituents spend hours poring over websites, brochures, trying to decipher what will be covered, which doctors or health systems may be in network when choosing their insurance plans. I believe one important way that we can help drive down healthcare costs and increase competition is by increasing price transparency. It should be easy for patients to understand what benefits are covered by their insurance and what they may be expected to pay. Our committee, by the way, has already done great work to achieve this goal, highlighted by the passage of the No Surprises Act in 2020, which will prevent patients from ever receiving an unexpected medical bill again. But more can be done on the front end to help patients understand costs before they seek care so they can compare coverage options and make market-informed health choices. The provisions in this package will improve provider directories, insurers' statements on their mental health coverage offerings, and mental health network adequacy. So I'm honored to co-lead one important provision being considered today called the Readable Insurance Coverage Estimation, or RICE Act, which, by the way, I think is very aptly named, with Congressman Rice and Congresswoman Plaskett. Under current law, insurers are required to publish their summaries of benefits and coverage, SPCs, which seek to lay out in plain English for patients what an insurance plan actually offers beneficiaries. This helps consumers know what they're paying for, what services will be covered, to help them make informed choices when comparing plans. But consumers today can't always compare how their plan offerings compare to others. The RICE Act takes an important step to boost transparency by requiring all SBCs to be published on a public website. Not only will this give consumers more information, but it'll also allow researchers, nonprofits, stakeholders, and the general public to have better insights into the coverage landscape. For instance, researchers could use the database to compare coverage options for a specific disease or region. Information would be shared more broadly, and potential gaps in coverage would be more easily identified. The RICE Act also commissions a report to recommend and define common terms that appear on an SBC so that all insurance companies will use the same language in their descriptions. This will ensure that SBCs are easily readable to consumers. So this is a common sense solution that will make our healthcare system more transparent, more approachable for our constituents. Thank you, Mr. Chairman. I yield back.
I thank the gentleman. I believe there's nobody else who wishes to strike the last word. So we will proceed to the amendment stage, and I understand there are no amendments. If there are no amendments, the question is on the adoption of the amendment in the nature of a substitute. All of those in favor signify by saying aye. Aye. Those opposed, no.
Aye.
In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. Now let me recognize Mr. Thompson for the purpose of a motion.
Mr. Chairman, I move that the committee agree to committee print 117-5 as amended.
The question is on agreeing to the committee print 117-5 as amended. Members are reminded to unmute themselves for a voice vote. All those in favor signify by saying aye.
Aye.
Those opposed, no. The motion is agreed to, and committee print 117-5 as amended is agreed to. I want to thank the committee members for their help today in getting through this, and it's also an accomplished stage for members of the committee and for their good work. There being no further business of the Ways and Means Committee, the committee stands adjourned.